and the techniques associated with the procedure. The most important component of post-op success with the premium IOL is preoperative assessment of the visual needs of the patients. Patients fill out a lifestyle questionnaire that helps devise a treatment plan that is appropriate for the patient's needs and desires. Understanding patients' expectations can significantly increase the likelihood of achieving happiness and avoiding a patient selection error. So you need to consider their current refractive error, personality, occupation, hobbies, goals, expectations, willingness to compromise, and particularly the ocular health. Educating patients about premium IOL surgery is very crucial. Psychometrics is MD Backline software visual profile reports. It's a cloud-based online service that collects information on patients' lifestyle, visual needs, and expectation, deliver educational material and premium lens implants beforehand, predict which patients are most interested in premium options, suggest who is going to do well with premium options, suggest options best suited to their needs. And we have to know the eye. We have to know the ocular surface. We have to know the vitreoretinal interface. With age, dry eye becomes more and more prevalent, which absolutely needs to be addressed before surgery, and this is particularly true for premium IOL patients. You need to make sure the ocular surface is pristine. So we need to do some dry eye workup, such as Schirmer test, tear breakup time, tear osmolarity, MMP9, LipiView 2, and we need to optimize tear film with artificial tears. We need to treat aqueous deficiency. We need to treat meibomian disease with anti-inflammatory eye drops, cyclosporine eye drops, and liftigrast eye drops. 80% of the dry eye is due to FGD. Now we can treat it with iLux, intense pulse light, and LipiFlow treatment. We should be cautious with pterygium, corneal scars, EBMD, SND, and with corneal dystrophies. Addressing astigmatism is very, very important. I generally advise toric IOL for patients with 1 diopter or more with the rule astigmatism, 0.5 or more against the rule astigmatism. I undercorrect with the rule astigmatism and overcorrect against the rule astigmatism. Presbyopia IOLs perform best with less than 0.75 diopter of cylinder. Exclusion of ectasia and keratoconus is very, very important. And now we have availability of corneal biomechanical analysis by Corvis ST. We need to exclude Fuchs endothelial dystrophy. Optic nerve and retinal diseases lead to decreased contrast sensitivity. And with multifocality, you will end up with further reduction in contrast sensitivity. So we need to be careful in glaucoma and glaucoma suspects. We need to exclude ARMD, CNVM, ERM, retinitis pigmentosa, diabetic retinopathy, retinal detachment, and macular hole patients. Ideally, all patients should get an OCT evaluation in all cases. The current technology is more forgiving, enabling surgeons to offer premium procedures to patients with mild dry eyes, glaucoma suspect patients, ocular hypertensive patients, early stable glaucoma patients, patients with previous refractive surgery with regular topography, few hard drusen, patients with extrafoveal drusen. Now we can offer these patients low-ad multifocals, EDOF lenses, and EDOF toric lenses. Precise biometry is very, very important. I use SwapSource OCT IOL Master 700 optical biometry. I use Barrett TK Universal 2 formula, and for toric also I have Barrett Universal TK toric formulas. I use Pentacam AXL also. The results are comparable. And for dense cataract patients, I recommend immersion biometry. Angle kappa or cord mu more than 0.5 millimeter is a contraindication to multifocal IOLs. And we need to be very, very careful in selecting patients with very small pupil and patients with zonular dehiscence. We should be cautious with higher order aberrations more than 0.5 microns. Particularly in post-LASIK and SMILE cases, the higher order aberrations and spherical aberration increases, so we need to be very cautious. Post-hyperopic LASIK patients usually have negative spherical aberrations, so we need to treat with a zero aberration IOLs. Now, which IOL to use? Bifocal IOLs are for patients who want to read close up with books along with fairly good distance vision. Trifocal IOLs are for patients seeking good vision for office purpose at the desk, computers, laptops, and smartphones. EDOF lenses are for patients who require intermediate and far vision, such as iPad, laptop, and e-readers. Appropriate patient counseling is critical to managing patients' expectations preoperatively, preventing misunderstandings and poor outcomes with premium IOLs. Patients are not looking for choices, they are looking for the solution of their visual need. Patients are paying out of pocket and they expect to pay for performance. Choosing the right patient is very, very important by understanding the patient's lifestyle needs and visual expectations. Patient needs to be strongly motivated for spectacle independence. He should be easygoing with realistic expectations, always under promise and over deliver. Understanding the eye, understanding the patient needs, happy customizations, always avoid hypercritical personalities. So you need to talk to the patient, discuss the strengths, weakness, and limitations of the premium IOLs, discuss what technology can do and cannot do. They may still need low power glasses post-operatively. Drive at night as a profession could be a problem, particularly to the bus and truck drivers, the airline pilots. Low myopes may be disappointed, hyperopes are the happiest. Counseling regarding bilateral surgery is also important. Neuroadaptation takes over. Everything gets better with time. Future issues of dryness and PCO needs to be discussed also. Surgeons should craft their personal protocols for meeting the unwanted challenges of premium IOL implantations. Planning for the worst by doing your best before surgery is equally important, such as realignment of toric lens rotations, enhancement with piggyback lenses, enhancement with LASIK, PRK, LRI, and IOL exchange. Choose the right technology for the right patient. Taking the time to understand patient's need makes the difference between a satisfied patient and a frustrated one. Spending more chair time pre-op, lesser will be needed post-op. So my take-home message is careful patient selection is crucial in achieving success with premium IOLs. Premium IOL selection is more art than science. Counseling and educating the premium IOL patients is very, very important. Screen the patient, screen the eye. Choose the correct premium IOL that best fits individual's lifestyle. Thank you for your kind attention.
Thank you, Dr. Harun. It was a spectacular beginning. May I request Professor Din Mohammad Nurul Haq to make brief comments on Dr. Harun's presentation.
Thank you very much. It has been a wonderful occasion, an excellent scientific program organized by BSCRS. So I'm grateful to all of its organizers. It has been an excellent presentation. It has been an excellent presentation by Dr. Harun Rashid. He has explained actually nicely the every pros and cons of the selecting a patient for premium IOL. And I want to make some comments because in my experience, I want to say that first of all, we should determine if the patient is a good candidate for a premium IOL. First of all, we should determine that. And then initial counseling by the cataract surgeons on whom the patient has the maximum confidence and trust is very, very important. And the maximum patient seeks advice from the cataract surgeon directly about which IOL they are suitable for. Cataract surgeon can counsel the patient and spend little more time placing his final opinion through some catchy words like the doctors or the surgeon can say, this is the best IOL I would definitely prefer, even for myself, in my case. So, and also, I have the access of all the premium IOL in the world. Rather, we can say all that we are using every FDA-approved IOL and which are the best IOL in the world. And this can give you the maximum freedom from glasses. Sometimes the patient can tell in front of the surgeon that the the doctors, I want the best IOL available in the world. In that case, it is easier to motivate the patient. Then you can say directly, this is the best IOL in the world. And I want to say that we should never tell our patient selected for multifocal IOL that the postoperatively they will not need to wear glasses, because it is never guaranteed. We say this is the best lens with latest material and the technology. And finally, we want to say that it's better to avoid most demanding patient for premium IOL.
So thank you very much, sir, for your nice comments. May our next presenter, may we switch over to our next presenter, Dr. Mahjiba Rahman Chaudhary. She will be speaking on biometry for premium IOL.
Respected delegates, a very good morning to you all. Today I will be talking about precision in biometry, which is very much needed when we are going for premium IOLs. So for perfecting our IOL power calculation, we need to keep on in mind a few things. Number one, that we need to prepare our ocular surface for biometry and cataract surgery. Secondly, is which machine we are using. And thirdly, what IOL formula we are using. So for preparing our ocular surface, we need to know that the impact of ocular surface disorder will lead to error in measurement. Secondly, the patient won't be satisfied after surgery and might say that the surgery is the lead of the dry eye. And lastly, there is a risk of infection due to the ocular surface disorder. So what we do is we have to incorporate a dry eye workup in our cataract planning. This is very simple, will only take a few minutes more. What we do is when we see the patient in the slit lamp, we must see if the patient is suffering from any meibomian gland dysfunction, what is the status of the cornea, and we routinely are giving a dry eye questionnaire workup to our patients. Once we see that the patient is suffering from dry eye, we must go for treatment aggressively. This I'm taking the BSCRS protocol. Why treat aggressively? Because we have to reduce the surgery delay time. That is why the patient came here for cataract surgery. For treatment, to reduce the inflammation, we can go for topical steroid and also oral antibiotic if required. And for treatment of the meibomian gland dysfunction, warm compression can be advised. So once treatment is done, we tell the patient to come back after 2 to 3 weeks. At that time, we again do all those tests, see the level of the dry eyes, and once we see that it has improved, we can go for biometry and cataract surgery. But one thing we have to keep in mind, that we have to counsel the patient that apart from cataract, the patient is suffering from dry eye, and this treatment must continue after even surgery. Once we have done with the dry eye treatment, we move on to the machines. There are so many machines available in the market. The question comes, what machine should I use? Firstly, to start with, whichever machine is giving us a consistent good result, we can start with that machine. But to improve our biometry, we must move on to optical biometers. Why is that? Studies are showing that optical biometry is giving better accurate result in axial length. Why is this? It measures the optical axial length rather than the anatomical axial length. And it measures the axial length from the corneal epithelium to the Brooks membrane rather than only the internal limiting membrane, which is measured by the ultrasound biometry. And over here, light wave is used rather than sound wave by the ultrasound biometry, which has a shorter wavelength and is also more accurate. And fourth, this is non-contact. So obviously the patient's compliance is much better, but most important than that, there is no chance of corneal indentation. So the axial length is more accurate. Also, we can have a measurement of the angle kappa here. Why is this important? We will talk later. And we also get a total keratometry by the newer biometry machines. So a few guidelines, whatever machines we are using, we must follow is that we have to ensure machine calibration. No eye drops can be given before keratometry. Why is this? Because our tear is part of our optical system. When we give eye drops, we change that. Also, our result of keratometry will be changed. And also, if it's any reading, K reading or axial length, if it's more or less than the average, we must do a recheck. Same, for this same reason, we have to do biometry of both eyes each and every time. Why? We need to compare and see if there is any discrepancy, and only then we can have a recheck. So these are the guidelines. Now let's move on to the IOL formula. I'll just be talking about one formula, that is the Barrett IOL formula today. Why? Because again, I'm just showing you a study. This shows that the newer formula are giving more consistent result. And specifically why I'm talking about the Barrett IOL formula. Yes, this is the formula that is available in the IOL Master 500 but 700. But more important than that, suppose I don't have an IEL Master 700, will I not use Barrett? Yes, definitely we can use Barrett, because this formula is available online free of cost in the ASCRS or APSCRS website. I'll just show that there are 5 formulas. The first is the Barrett Universal Formula, which can be used for all eyes of all axial length. Second is the Barrett Toric Calculator for correction of pre-existing corneal astigmatism with toric IOL. And the third one is very important, that is the Barrett True K formula for prior refractive surgery patient. This is used, and only last year Dr. Barrett has improved this formula by making it the Barrett True K TK formula. Now the total keratometry is being used here, so this formula can now be used for biometry of keratoconus eyes even. So this is very important. The fourth formula is the Barrett True K Toric Calculator for prior refractive surgery eyes with corneal astigmatism. And the fifth formula, Barrett RX formula, can be used for IOL exchange or piggyback IOLs. Now, since we are talking about premium IOLs, I'll talk a bit about biometry for toric IOL. So when do we know that the patient requires toric IOL? Is by seeing the preoperative corneal astigmatism. So what is that? That is, obviously we know, is the difference between the K1 and K2. If this is 1 or more, this patient is definitely a candidate for toric. If the astigmatism is regular, that is the steep and flat meridian are 90-degree apart. We will just see an example. This is a biometry. We can see that the K1, K2 difference is 1.1, and the astigmatism, the difference between the two axes is 90-degree apart. So definitely I will think that yes, this patient I can go for toric IOL. But one thing we have to keep in mind, that total corneal astigmatism is now the summation of both the anterior and posterior corneal astigmatism. But that K1, K2 difference, that was just the anterior astigmatism. So where do we get the posterior corneal astigmatism for? Why do we need it? Because studies are showing that when we include the posterior corneal astigmatism in our measurement, the toric IOL calculation becomes much more accurate. And again, Dr. Barrett has made our life easier, because in the Barrett toric calculator online, already the posterior corneal astigmatism is being included, as we can see here. So what we do is we just put in our data and we get the IOL power needed, the model of the IOL, and lastly, as we can see, that the axis of placement for this patient is 90-degree. Let's move on to presbyopia correcting IOL. The main problem with this patient that they face halos and glare. Like for some patient, as we can, the patient can see clearly at night, no problem. But for some patient, we can see that the halos are glare, like the fourth picture is so much that patient cannot do any work. And they are like, what lens have you put in me? So can biometry help us in suspecting that which patient can have halos and glare? Yes, it can. For that, what we need to understand is the angle kappa. Angle kappa is, if we think, is the angular distance between the pupillary axis and the visual axis. So if we see here, this is there in the eye, there is a yellow dot and the blue dot. The distance between this is the angle kappa. If the angle is small, that is the distance between the blue and yellow is small, the patient usually don't suffer from halos and glare and is a good candidate. But as we see in this eye, that the yellow and the blue dot are far apart in the second eye, so this patient has a more chance of suffering from halos and glare. Why? Because when the light travels, it might hit the diffractive rings. This is where the halos and glare comes from. How do we know that where is the angle kappa more or less? Again, our optical biometry is here to help us. In ILMaster 700, there is a measurement included. This is the chord. So what we will do is we will just ignore the signs. I'll just make it simple. So the summation of these two values, that is the px and py value, we just need to keep this in mind. If the summation of these values are more than zero point 0.6, this patient will suffer from halos and glare, and we should avoid multifocal IOL in these cases. And lastly, before ending, I'll say that by incorporating dry eye workup in our practice, by using more than one machine, and one of them should be optical biometers, and by using the latest formula, we will have more perfection in our biometry. We will be able to provide the targeted refraction for the patient will be happy, and obviously the surgeon will be satisfied. Thank you for your hearing.
Thank you, Dr. Majiba, for your wonderful presentation. As we are fighting with the time, uh, we'll have special extra time in the discussion session, that is question and answer session. Just I want a little comment from Professor Dr. Kader regarding presentation of Dr. Majiba.
Uh, can you hear me? Am I audible?
Yes.
Yeah. Thank you very much. Thank you for giving me floor. Uh, uh, Thank you, Dr. Mahajiba Rahman Chaudhary, for your nice and well spoken presentation. It is very well explained and well documented. Thank you very much. For IOL, premium IOL patient, always there is expectation is very high. This expectation is very high due to they are try to free from contact lens and spectacle after the operation. So for that reason, we always try to premium result from this premium IOL. For that reason, the IOL power is the prime importance in post-operative outcome. For in 1 millimeter difference in axial length, there will be 2.5 5 diopter difference in power after cataract surgery. So the axial length is very much important in measuring the biometry as well as keratometric reading. If there is difference in keratometric one diopter, the post-operative also one diopter difference in outcome of premium IL. For that reason,
Thank you,
thank you very much.
Dr. Kadir. We'll be listening more during the question answer session. Now, may I request our next presenter, Dr. Ashraful Haq. He will be speaking on marking for toric IOL.
Dear delegates, a very good morning to you all. Welcome to the annual conference of Bangladesh Society of Cataract and Refractive Surgeons. Today, my talk is the marking for toric IOL. So when we talk for the marking of the toric IOL, we will be focusing on the reference marking and the axis marking. So what is reference marking? It's always we do pre-operatively, and it's usually to 0 to 180-degree axis in case of left eye or right eye. And it should be done in the sitting position to the patient. And the axis marking, it is done pre-operatively or par-operatively. The axis marking is the calculated axis where the dot of the toric IOL is aligned. So when we are talking about this alignment, we need to know why this alignment is very important. We know that For every degree of IOL rotation, 3.3% of
The
lens
presentation is not
Backup,
running.
backup team,
lost.
is the slide
So,
moving?
for
Okay, it's moving
example,
right now.
the patient has the astigmatism of 2.5 diopter, and there is the error in the pre-op marking occurs 5 degree, and error in the intra-op alignment is 5 degrees. So we have the total 10 degree of error of alignment. So when there is a 10-degree error, there is a 33% loss of astigmatism.
The
So
presentation is not
patient
running. Backend
of
team,
2.5
can you please
diopter of
check?
astigmatism, we are correcting only 1.75 diopter instead of 2.5 diopter. So there is actually residual 0.75 was not corrected. So this is very important. And the picture shows that pre-op reference marking, that is the horizontal to the eye, that is we usually do in the temporal side, and the intraoperative axis marking, what we usually do. In case of reference marking, we can do freehand marking, we can do bubble marking, or the marking by the slit lamp. So when we do the freehand marking, we have to keep in mind that patient should be in sitting position, and it's better practice to keep the patient's head against the wall, and we need to dry the cornea, because in wet dry cornea the marking could go for smudging or it is fade, and we need to hold the torch by our assistant straight to the eye, and the marking person is best to do by the surgeon by himself or herself. Sit little bit aside that patient can look straight to the torch or source light. So when we are talking about this torch, the light reflex, we need to follow the corneal reflex, because the corneal reflex should be in center, and that we can draw an imaginary line, and with the imaginary line we can easily draw the reference marking, which is what I told, that is temporally, that is 0 in case of left eye and 180 degree in case of right eye. So the middle picture is the correct. And in case of this marking, the mark should not be irregular. It should be like a dot or a straight line that we can easily understand where it started. So before doing the marking, we need to do topical anesthesia. This is the very must thing. Otherwise, patient cannot do, will not allow us to do the marking. And we have to instruct the patient where to look. And this, the freehand marking. This is the eye. We just draw, put a line that make as a reference marking. We can also do it by slit lamp. The Zeiss slit lamp has the axis marking system, and here this is 90, and if we want to do the 180 degree, just we can rotate it, and here it shows that 180 degree, and the beam is parallel horizontally, and when the beam is horizontal and it gives us the mark of 180 degree, we can just make one reference marking here. We can also do axis marking by the slit lamp also. But when we are doing the reference marking, so how we can understand that this reference marking is actually 180 degree or little bit apart? There are now in the advanced world, there are two mobile apps that makes us very easy for the confirmation of the reference axis. One who is using the Android app for the Google Play Store, iToric by Patvardhan, and another is the Toricam by great Dr. Graham Barrett for the Apple users, are available in the market, and it's free to download. So we can easily understand that our reference marking, what is the actual axis of our reference marking by these two apps. But one thing, that when we use this mobile device, we need to keep in mind that the head of the patient should be stabilized, and the head of the patient, look at this picture, the head of the patient and my mobile position should be parallel. The mobile position should not be tilted. If it is tilted, it could give chance to an error of my reference marking. And also when we have to take the picture, we have to look the corneal red reflex, and the limbal line should be in the center, and our corneal light reflex should be in the pupillary center, and the middle picture is correct. And this is the Toricam. Just we took the picture. That's a very easy apps by Dr. Graham Barrett. Just we take the picture, and this picture, when we give the manual reference marking, this picture gave us that what is our actual reference marking. Look at the first picture. It is our manual marking is accurate. This is 180 degree, and another picture, this is, we intended it for 0 degree, but it is 1 degree. So if we have a little bit 5 degree or 175 degree, this also indicate that what is the reference axis by this app. Now we go for the iToric. It's a very good app for the Android user. That what we need to do, we have to align the corneal reflex at the center, and then we will take the photo. And then what we do, we will manually align the cornea with the circle. Look at this. Then after that, we drag the one point and at the mark, and another through the center of the circle, and that give us the misalignment. Look at this, the rotation, mark rotation is indicated that it is 17 degree. So my misalignment is 17 degree, and though this is the left eye, my reference marking is also in the 17 degree. So that comes to the axis marking. Axis marking is where my toric IOL dot will be aligned. So for the axis marking instrument, these are the instrument set, and we have to use the Mendes ring, because the Mendes ring have the axis marker here, and this is the manual axis marker. So before the axis marking, we need to understand that where I did my reference marking before placing the Mendes ring. Because look, in this first picture, there is the mark rotation was 35 degrees. So my reference marking is, it is this minus 35 degree. This is called minus 35. And so when I put the reference Mendes ring, my Mendes ring 155 degree should be aligned with the my reference marking 155 degree. Then I will proceed for axis marking. Otherwise the toric IOL axis calculation will not be correct. And this is the video, the reference marking. This is the axis marking, and just 180 degrees the reference marking was there, and 20 degree was my axis marking, and we place it sharply there, the with the ink. And we always need to remember that if there is any chance it becomes fade, we need to enhance it during the surgery. We never compromise with this axis marking. And nowadays, life become more easier because of digital marker like Varian and Callisto is here. What it does the pre-operative count, and after the pre-operative count, we take it to the OR and set it with the machine. Here we are showing the Callisto machine, and then the machine gives us the axis of alignment. And look at the picture. There is the blue line is here, and blue line is my axis marking where my toric IOL alignment should be done, and we align the toric IOL with this blue marking. In the new generation of the Callisto machine, it is 3 blue lines, so it gives more accurate thing. But this machine, and this is the alignment of the axis, and so the axis marking is done with the digital marker. So the take-home message for the beginner, we need to start practice the freehand marking. Then we can go to slit lamp marking, digital marking. And for every surgeon who are doing the toric IOL, it's a good to install Toricam or iToric app. It makes life easier. And when we do the marking, when we do the reference marking, when we do the axis marking, we should be patient, never to hurry. And always we need to remember the meridian of reference marking when we doing the intraoperative axis marking, because if we calculate wrong reference marking, the axis marking will be wrong, and the toric IOL placement will be wrong also. That will be a very bad for the patient as well as for the surgeon. And I want to say, end my talk by saying the great talk by Dr. Graham Barrett, who has lots of contribution in this toric IOL calculation that determine the exact location of reference axis when implanting toric IOL increases the rate of success. And remember, knowledge upon location and direction is required to arrive at one's destination in life as well as in the cataract surgery. Thank you very much. I would like to take any question if there is any. Thank you very much.
Thank you, Dr. Ashraf. may I draw the attention of the backend team? We were a little bit lagging behind with the slide rotation. May I request Professor Dr. Mijan to have a brief comment on the presentation of Dr. Ashraful Haq?
Thanks, Dr. Kamrul Islam Khan, and good morning to everybody. Actually, post-operative perfect vision is our desire, and for correction of pre-existing astigmatism is mandatory. And I think Dr. Ashraf nicely shown how we can correct the astigmatism and the marking, that is the reference marking and the axis marking, how it can be applied and how it can be measured. That he has shown nicely. So I must thanks to Dr. Ashraful Haq for his nice presentation, and I think we should practice his correction of pre-existing astigmatism for the post-operative spectacle vision. Thank you, everybody.
Thank you, Professor Mijan. We'll be having a few questions after the discussion session. May I request our next presenter, one of our legend, Professor Dr. Jalal Ahmed. He will be speaking on pearls for toric IOL surgery.
Assalamu alaikum and a very good morning to all participants, respected chairperson, panelist and moderator. Welcome to my talk on toric surgical pearls. Before toric surgery, patient selection, accurate biometry, toric calculation, IOL power selection, counseling, reference and axis marking is very important, which is already nicely presented by our previous speakers. Basics of toric IOL surgery is to correct regular corneal astigmatism by placing a spherocylindrical IOL in lenticular plane on the calculated axis. Precautionary measures are taken to prevent subsequent rotation of the IOL. Anesthesia can be given both topical and perivalvular. Then, regarding the surgery, the surgical technique is almost like a normal phacosurgery with IOL implantation, with few points to be given emphasis on incision, rhexis, hydroprocedures, nucleus management, cortical cleaning, IOL placement, and wound closure. Incision placement should be on regular site of the surgeon's own practice, but the important thing is it is to be entered in the calculation formula as shown in Barrett toric calculator printout. It is a video showing side port incision and main incision. It should be self-sealing tunnel incision, and care should be taken not to induce more surgically induced astigmatism. So incision can be near clear corneal, not too much towards the center of the cornea. Capsulorhexis is very important. Regarding the size, it should be slightly smaller, like 5.25 millimeter, central, circular, and should 360-degree cover the optic of the IOL. Rhexis can be done freehand or using a marker, manually or digitally, with digital marker or with femtosecond laser. This is a screenshot of my toric patient showing 360-degree optic, nicely covering by central circular rhexis. Phaco should be uneventful or without complication. In all premium IOL surgery, we want to give high quality vision, and patient's expectation is also very high. Stop and chop, divide and conquer, or any chopping technique according to the surgeon's choice, but meticulous cleaning of the cortex and capsule polishing is to be done where needed to prevent posterior capsular opacification. IOL placement: initially IOL is placed 15 to 30 degree off axis, and IOL will rotate while removing OVD, and final positioning is done after complete removal of OVD. Here is IOL is placed in the bag and wait for complete unfolding of the optic, and first it is placed 15 to 30 degree off axis. Here is a screenshot of the initial placement of the IOL. yellow arrow showing the mark on the optic of the IOL, and the blue circle showing the axis mark on the eye. So it is more than 30 degree off axis. Now, regarding visco removal, complete removal of the viscoelastics is very important. First, I remove the viscoelastic from the front of the lens. Then I go behind the lens and in viscoelastic mode and remove. After complete removal, I try to remove the viscoelastic completely. Then I again come in the front of the lens and remove the viscoelastics completely. And after removing the viscoelastic, I try to place the lens on the axis on the line of the axis marking of the eye. And when it is complete, then I remove the phaco tip in such a way that the wound is AC is not over tight, or AC should not collapse also. It is a still image showing digitally final placement of the lens in the eye. During the whole surgery, maintain adequate pupillary dilatation. Sometimes during phaco, pupil becomes smaller. In that case, we can use diluted intracameral adrenaline so that pupil remains dilated and all the time during the whole period of surgery. Wound hydration and closure is similar whether you do digitally or manually. Here is a digitally. I am using wound hydration is done in such a way that overhydration or AC collapse do not occur. And here it is done manually. Wound hydration is done in such a way that overinflation or AC collapse do not occur. If overhydration occurs, fluid may go behind the lens and it push the lens forward, so position is changed. And if AC collapse, there is risk of change of position of the IOL. Here is a video showing axis marking. First axis marking is done, then side port incision. Here is the main incision is given in such a way that it is a good tunnel incision. Rexis marker is placed. Then with 60-tome needle, capsulorhexis is done in central, circular, and slightly smaller than normal size. Hydrodissection is done, and then phacoemulsification is done. I usually use the vacuum of the phaco and side port instrument to fragment the nucleus. After fragmenting the nucleus, multiple fragmentation and emulsification is done to remove the nuclear fragments. And after removing the nuclear fragments, cortical matter is cleaned by using IATIF or coaxial or bimanual IATIF. And after removing the cortical matter, IOL is implanted and complete unfolding of the haptic is done first. Then I remove the viscoelastics from the front of the lens and from the anterior chamber, and then I go behind the lens and try to remove the viscoelastics completely. Dispersive viscoelastic should not be given in the bag because it is difficult to clean. Then I come in the front of the lens and press the lens on the posterior capsule, then clean the remaining viscoelastics and cortical matter. Try to remove completely, and then final positioning is done so that the lens mark and axis mark remain in the same line. Then wound hydration is done in such a way that overhydration or AC collapse is avoided. If overhydration done, fluid may go behind the lens and it push the lens forward. And if AC collapse, there is risk of also changing the position of the lens. So it should be optimally closed. Immediate postoperatively, we usually advise the patient to keep rest in bed in lying position for 1 hour, because most of the rotation occurs within 1 hour after surgery. After 1 hour, slit lamp examination is done, and this narrow slit beam is placed on the axis of the IOL, and it is read on the scale. So scale of the slit lamp, so you can easily see the position of the lens in the eye. Why it is so important to monitor the position of the lens within the eye? Because 1 degree rotation causes 3.3% loss of cylindrical power. 10-degree rotation causes 33% loss of cylindrical power, and 30-degree rotation causes total loss of cylindrical power. More rotation will induce more astigmatism in newer axis. It is a slit lamp photograph in dilated pupil showing the position of the lens postoperatively. Before ending, there are some pearls to remember: proper preoperative measurement and case selection, accurate reference and axis marking, safe and uneventful surgery, correct placement of the IOL in the bag, thorough OVD removal, adequate wound closure, and subsequent monitoring of the IOL position will give best outcome and quality vision to our toric patients. Thank you all for your kind attention.
Thank you, Professor Jalal. You have been a mentor for all of us for your wonderful presentation. May I request Professor Sarwar Alam, one of the good renowned mentor of the phaco surgeons in the country, to put some comments regarding Professor Jalal's presentation.
Uh, Thank you very much. Actually, after the beautiful presentation of Professor Jalal, very little to say. Among the general cataract surgeon, phaco surgeon, there is a fear for doing premium oil, especially the toric oil implantation. But there is no need to acquire new skill set other than very accurate biometry and the marking procedure. So everyone should come forward. And there are some benefits in the toric oil implantation over the other premium IOLs, that it does not hamper the contact sensitivity, and it is very useful if we can implant it in child for treating amblyopia. Even if we have a minor macular problem, we can implant, which we cannot implant in the other premium IOL. And here there are some points to remember, which already have been mentioned. And there is a very problem in marking, that during marking, the ocular surface should be totally dry. Otherwise, the spot might be more span more than 10 degree, and there is chances of rotation in every step of surgery. So we should take care of that thing. And even there is a saying that we should try, but if it is problematic in someone's hand, they should be more cautious, because very minor degree of error will be detrimental. So thank you again, and we hope that our surgeon will come forward for this thing and learn from the mentors. Thank you.
Thank you, Professor Sarwar Alam, for your wonderful comments. May I request our next presenter, Dr. Abdul Rakib Fisher. He will be speaking on pearls for presbyopia correction during cataract surgery.
Very good morning and welcome to you all to annual conference of Bangladesh Society of Cataract and Refractive Surgeon. Thanks to BSCRS team to give me the opportunity. Today, my talk of pearls for presbyopia correction during cataract surgery includes how we make preoperative assessment, surgical pearls, and a special consideration. Before going to detail, few thoughts of cataract surgery. Every cataract surgeon is increasingly made with high expectation of patient. And what are the expectation? Superior quality of vision, excellent uncorrected visual acuity outcomes, decreased dependence on glasses in all activities. And it is now when we can meet the expectations. Though it is crucial for predictable outcome of cataract surgery, it is almost possible to give the patient the best vision without a spectacle because we have modern biometry, modern formulas, advanced cataract surgery techniques. This surgery is uneventful. Patient does not have any other coexistence abnormalities. Intraocular lens is well centered. Still, postoperatively patient need spectacle. Before considering the presbyopia correction during cataract surgery, there are some contraindications like corneal irregularities, retinal disease, end-stage glaucoma should be excluded. Next, important preoperative thing to consider, the customized patient need. The need of an office executive and elderly housewife is not same. So choice of intraocular lens depends on the particular patient. Another important point to consider is previously refractive or any other ocular surgery because it will change the choice of biometry, its formula and type of presbyopia IOL also. Astigmatism. Because modern cataract surgery is more of refractive surgery, looking for pre-existing astigmatism is very important. The fact is, 20% of patients with cataract have significant astigmatism, and every incision on cornea induces additional astigmatism, that is, surgery induced astigmatism. If we do not consider the astigmatism during cataract surgery, implantation of monofocal IOL will require distance and near correction both in these cases. The next important thing is biometry. My previous speaker, Dr. Mahajiba, elaborately talked about it. I just want to add, please use optical biometry if possible with online calculator of power of IOL in every cases. Now you have a lot of armory of IOL like traditional multifocal IOL, extended depth focus intraocular lens, accommodative intraocular lens, monofocal blended vision, toric multifocal lens. But which lens to choose? The best answer to communicate with the patient regarding the choice of IOL. The key is to educate with the right information, short and to the point. Too much information can confuse them. This is the most important slide because after well communication, the patient still wants to be told which option is best for them. A strong, well-informed recommendation is the key to assisting the patient with a lens choice. Now, the multifocal.
Hello, Professor Kamrul. Is there any problem with the
The
transmission?
main tip of surgery of a multifocal IOL is not to overthink. Do as usual wound construction. Be sure of central, circular, continuous capsular axis formation. Emulsified nucleus normally. Give emphasis to meticulous cleaning of cortex.
Do you hear any sound?
Try to position a multifocal IOL in the central of the capsular bag. At
we
last,
can't hear
not
anything.
least, wash out the OVD even behind the intraocular lens because it gives well centralized position of IOL in postoperative period. After doing the hard work of uneventful surgery, you can face complaints because no one is perfect. Before going to surgery, definitely we acknowledge the disadvantage of multifocal IOL like increased light intensity, decreased contrast sensitivity, off-axis aberrations, glare and halos around light at night, a feature that is inherent to multifocal lenses. But remember, a few patients will complain about this. And moreover, most patients find that they get to use this phenomena with time and the glare and halos become less obvious. The relatively new extended depth focus lens has excellent properties to overcome the demerits of multifocal intraocular lens. It gives the patients continuous range of high resolution of vision, provide high quality continuous vision so patients can see clearly at near, intermediate and far away distance and points in between them. It provides seamless day to night vision. It demonstrates a low incidence of halo and glare. This surgery is with extended depth focus intraocular lens. Does any unusual maneuver needed in this surgery? No. The main consideration of EDOP IOL is intermediate vision. So it is excellent choice for office executive who is sync with computers. But question remains, does it answers all the questions? Traditional multifocal IOL or EDOP IOL does not address the pre-existing astigmatism. The main tip of this surgery is to combine the techniques of toric IOL and multifocal IOL. These are preoperative corneal marking of steep axis, as usual wound construction, central, circular, appropriate size capsular axis, conventional way nucleus and cortex management, meticulous cleaning of capsule, simultaneously OBD removal as well as IOL rotation, removal of OBD from the undersurface of intraocular lens is very important. Roughly seal the wound before the final alignment of intraocular lens. Final alignment of IOL is the next step, and last step is wound sealing. Despite all the steps of preoperative assessments and surgical hard work, it does not give predictable outcome. Here comes technology. Flax, which has great potential advantage for predictable outcome. Femtosecond assisted laser cataract surgery gives a better outcome, especially in case of multifocal IOL. The main technical advantage we can get from flax are perfect incision, perfect capsular axis. In flex, position of primary and secondary incisions according to the surgeon convenience can be formulated, can be according to the pre-operative astigmatism. In one sentence, flags keep less surgery-induced astigmatism. In flex, what are the advantages about anterior capsulotomy? It is continuous and perfectly centered. It is precisely determined diameter and depth of capsulotomy. It is potentially stronger with less chance of anterior capsular tear. It is ideally centered in respect of limbus, and size can be set in any diameter, but the standard diameter of the capsular axis is 5 mm, and it can be easily set by femtolaser assisted cataract surgery. Regarding the nucleus management by flags, is there any advantage? Yes. In a nutshell, in flags, there is a less energy delivery, there is a less assault to the wound, and ultimately it leads to less surgery-induced astigmatism. My take-home message, it is time-needed requirement to correct presbyopia during cataract surgery. The best way to do is think that you can do multifocal IOL with confidence. Update yourself with latest knowledge like online IOL calculator. Do not think new technology is always clumsy and hard to accomplish. Lastly, but not least, be communicative with your patient. Thank you, and thank you all for having me.
Thank you so
Thank
much,
you,
sir.
thank you, Dr. Tushar, for your wonderful presentation. I request all respected panelists to prepare questions because we will have a question answer session at the end. May I request Professor Kader to put some brief comments regarding the presentation of Dr. Abdul Rakib Tushar.
Thank you very much. Uh, I must thank Dr. Abdul Rakib Tushar for his nice and well-delivered presentation regarding presbyopic correction in premium IOL surgery. Patient want to see distant, intermediate, as well as near vision clearly after surgery. For that region, presbyopic correction during surgery is very much important. It is very new thing, so we must cope up with this and come forward to this type of surgery and to popularize this surgery. One thing is very much important. Those patients who see distant vision clearly, this is not be a good choice for presbyopic correction. Thank you very much.
Thank you, Dr. Kader. Uh, uh, Respected audience, uh, our next presenter, that is the last presenter of this session, is a legendary personality. We frequently see his videos in different medias. Uh, not He is the not only a mentor as well as a teacher also. He is Dr. Deepak Megor. He will be speaking on post-operative refractive surprise, how and when to fix it.
Good morning, everybody. Am I audible, sir?
Yes, you are quite audible.
Yeah. Thank you so much for the invitation, Bangladesh Society of Refractive and Cataract Surgery, and thank you all the panelists for having a wonderful session here. I'm really impressed by the meticulousness which you planned and executed the meeting here. My topic is going to be on post-operative refractive surprises. It is not going to be purely on premium lenses. It's going to be on every type of surgery which we do, because post-operative refractive outcome is critical irrespective of what lens we put in. So let me share briefly of my experiences. My first case, I had an experience about few years back. 25-year-old patient presents 14 years after he was undergone a cataract surgery as a child when he was just a 10-year-old boy. And records show that he had been used a low power lens. It's about 10 or 12 diopter lens, suggestive of pathological myopia. But he presents to me with a clinical picture like this. Now you can see that the PCO is very thick, and I didn't want to yag him because of the risk of retinal detachment. I thought I'll just do surgical polishing of the posterior capsule here and let's see. So the technique which I'm using, I'm just holding an irrigating cannula here and using a blunt spatula to create some space. So using a combination of blunt dissection and visco dissection, I could get access into the space behind the lens. I'm just aspirating all the Elschnick pearls and all the material which was causing the pacification. It was just took a few minutes for me to clean up all the thing, and I thought I was very happy and congratulated myself for doing a wonderful job. In few minutes, the visual access were very clear, and I was pleased. But little did I realize that the next day, a very unusual surprise waited for me. And patient had a residual refractive error of -6 diopter. Imagine this is a young male who's a working male, and the only option which I thought at this stage was to consider and go ahead and do an IOL exchange. So this was a PMMA lens which was implanted about 14 years back. The surgery was done quite well. The rexis was very well done. And now I had to remove the PMM lens. This was the first time I'm removing a PMM lens for refractive surprise here. I could dissect out the lens quite easily using a combination of viscoelastic and blunt dissection. I could do it without damaging the bag. The bag is again filled with viscoelastic, and I'm using a hydrophobic multi-piece lens which has got a lesser chance of inducing posterior capsular pacification. It's a very important criteria in such eyes with myopia. And of course, you have other options to take care of refractive error, but in this situation, again, I chose to do refractive lens exchange here. And since it was, I was inducing some against it, I did suture the wound, and I did have a reasonable good outcome in the post-operative period. So let us to summarize here. No, refractive surprises, I think each one of us would have encountered in our practice, and following are the common reasons which we have here. And difficult eyes, extremely myopic and extremely hyperopic, and post-refractive surgery, you do the best you can, but still you end up having the surprises. And of course, we have got multiple options available with us, from starting from laser surgery to putting a piggyback lens and ion exchange, and a simple thing like just removing the viscoelastic behind the lens. And in my experience, the last many years, a wrong lens is one of the most important cause for refractive surgery. It is just a human error. This one case where I had a residual refractive error of -8, and the simple reason was a wrong lens was implanted in this patient. The assistant gave us a 16 diopter lens instead of a 6 diopter lens. And another common reason for this transcription errors always are going to be, many patients having the same name. If you don't just concentrate on the initials, in a high volume practice, it's going to be a very recurrent phenomenon. I think the simple solution is, to have a robust system to nullify this potential error. Always do a double check and cross verification. I think a 1 minute pause just before you implant the lens, and take a time out and read all the documentation again and confirm the eye, the patient, and the lens before implanting is going to be a good habit. Now, moving to the next case. This is a young patient who had complicated cataract because of uveitis. I implanted the lens. Next, again, I am having this post-operative surprises of refraction of +2. And the patient is extremely unhappy, expected. He's a young male patient, and we just want to go back and investigate what went wrong here. When we go back and see the axial length, it is 24.4. Slightly myopic, nothing unusual here, and we chose an SRKT formula of 19.5, which was giving a good distant ametropic vision, but still went wrong. So what was the key here was two important parameters which are not discussed often. We did not look at the AC depth here, which was unusually high. It's almost nearing 5 millimeter, and look at the K reading. It's 41, less than 42. These are outliers. The traditional formulae, including your Barrett's Universal 2 formulae, really don't do a good job in this situation, because the effective lens position was there. And just when I went back and saw, the only Haigis was the one which was giving me a power which is significantly higher than what we were traditional formula which you're using. So this is something of a lesson which I learned. This was about 3-4 years back. And what was the solution for this case? Well, it's an unhappy patient. You can't sit on this patient. This was a single piece hydrophobic lens. And the only way I thought would be to do an exchange. And at 1 week, I just took him into the OT, and I did a lens bisection or trisection, and then removed the lens. I usually want to divide the lens into 3 pieces so that I can remove it comfortably in the 2.8 millimeter incision, which I have originally used. Of course, using the right instrumentation and learning how to use them is extremely critical for all phaco surgeons, because lens explanting technique is a thing which all of us have to master here. And then I again went ahead and implanted the lens. I still was not sure to go and correct him fully. I still undercorrected by maybe 0.5. Again, I was left with 0.5 diopter spherical error. So the message here would be very clear. When all the formulas, including the Barrett's, they're all designed to work with assuming that the patient's cornea keratometry reading is between 41 and 47, and ACD is about 3.5 or less. But any situation where you have a K reading less than 41 or more than 47, or you're having an unusually deep chamber, you need to work around, because the effective lens position is going to change. In my experience, using the Haigis formula, a combination of Haigis and Barrett's Universal 2 is going to work. Another quick example here, a recent case, he is a myope. Look at his antechamber depth, 4 millimeter, and look at his K reading. It is 41, 41 diopter or 42, less than 42. So it's borderline thing. And all of each of these formulae give us different readings here. So this is a premium patient. You don't want to mess up with this thing. So which formula are you going to choose here? Because I was dealing with a slightly flatter cornea and a deeper chamber, I went with 17 diopter, which is 0.5, then the highest what was predicted by most formulas. But still, I ended up just that. I just ended up not having a spherical error. So again, you need to look into these parameters of the keratometry reading and the antechamber depth before choosing your formulas. That's an important take-home message. Of course, the other way of fixing postoperative refractive surprise always is going to be using a Sulcoflex lens. This is a hydrophilic lens manufactured by Rayner, which is custom made for sulcus fixation because it has got a bigger optic size and also overall length of 14 millimeter. The haptics are extremely thin, and hydrophilic material being extremely biocompatible with the UL tissue, it really does well. And introducing it is extremely technically easy, not an issue. Probably the only issue is the cost here, because it's quite expensive in a country like us where we will be paying it out of our pocket. I think it's patients, most of them will be reluctant to pay for it, and we need to decide what is there. And of course, the next option always is going to be laser if you have an access to laser. Depending upon the patient's residual refractive status and the patient's corneal status, you can choose that as well. Now, moving on quickly to the residual astigmatism after IOL surgery. I think there is a beautiful website called as astigmaticfix.com. You just have to enter the data of the residual error which you're having. And you also guide you regarding what is the position you need to fix and what is the amount of rotation you have to do it. So that's an invaluable tool to have. Well, the most common cause for mild toric eye rotation is always going to be a residual OVD. It's a good habit to master the art of removing the entire OVD before placing the lens into its final position. And this is my final case. It's another case where a simple transcriptional error was a cause. I had a residual refractive error of 1.94 in a young lady with intermediate uveitis. We decided a toric intraocular lens implantation, and the toric IOL was implanted. Surprise, surprise, I was left with more residual refractive error than what actually was original. The main problem here was, you can see the orientation is done at approximately 170 degrees, but the fact is it had to be 90 degrees. It had to be here. It was just 90 degrees away from the intended. This was just a transcriptional error, the way I was looking at the map. And the message here would be never take anything for granted, even if you have done a lot of experience with this. And the way I fixed it is just about 5 days or 1 week post-op. I took the patient, it's just an irrigating cannula here because the lens is still not attached to the capsular bag. It's relatively easy for me. So not using any viscoelastic, just using an irrigating cannula. I'm just manipulating the lens into the desired position, which was 90 degrees onward. And you just hydrate the wound, and that's it. The case was fixed. The message here would be, if you want to rotate the toric lens, it has to be within the first 15 days or maximum 3 weeks. Later than that, it's going to adhere to the capsular bag and make it life difficult. So thank you so much for your patience, and thank you for the program. I enjoyed a lot.
Thank you, Dr. Deepak Megur. It was a wonderful presentation, a lot of things to learn from your presentation. May I request Professor Sarwar Alam to put some comments, brief comments regarding the presentation of Dr. Deepak Megur.
Thank you, Dr. Deepak, for the beautiful presentation. Actually, all the premium IOL surgeons should be psychologists or psychiatrists. They should read the mindset of the patient, because even if you don't communicate with them about their expectation beforehand, they might say that I can see the computer, I cannot see the reading part, or else vice versa. So we have to have a good conversation with the patient and know the mindset of the patient. And also, we should not ignore the problem of the patient, hide the problem of the patient. That is nothing. We should address those for keeping our prestige to the patient. And we must be skillful in doing our surgery, because in other surgery, a minor error might not be so affect the outcome of the surgery. But here, post-recapsular rent, heptic in the sulcus, wrong biometry, wrong, not optimum size capsulorhexis, these will have a great impact on the outcome and can produce the refractive surprises. And there is a beautiful practice of posting or the chart of the biometry on the wall of the OT, so that surgeon can check and recheck again and again. If the patient, as it has been said, that if the patient has a blurring in the vision, if it is the code is the refractive, then we have to address it with whatever option we might choose, like LASIK, PRK, LRI, feedback lens, what already has been said. And sometimes there are also some problems of might shift, and then shallow AC, then YAG laser might have to be done. So these are very minor things, but this has to be addressed. And also, there is a saying that premium IOL implantation and satisfaction to the patient may not be applicable for all the surgeons. In USA, only 20 to 25% of the phaco surgeons are doing premium IOL. So it needs a very meticulous evaluation and dealing with the situation and satisfy the patient. Thank you.
Thank you, Professor Sarwar Alam. We had a wonderful presentation as well as a comment session. Now we have got a little bit of time to have a question and answer session. May I start with Professor Din Mohammed, sir? You can ask questions to any of the presenter, or sir, if you want to make any comments regarding any particular presenter. Sir, we cannot listen to you.
Hello. Can you hear me now?
Yes, sir. Yes, sir. Loud and clear.
I have three questions. One question to Dr. Maziba. That is the IOL calculation for patient with who has done excimer laser before and lost all the previous records. So how can you measure the IOL power in that cases with no previous records, but the excimer laser done before?
Okay, Dr. Majiba, please.
Thank you so much, sir. So that's a very important question. Sir, what happens is, as I was showing, that the Barrett calculator, it does not require any previous data. We will just do the biometry now, and then we can just put in the data that we get now. For Barrett calculator or pre-LASIK calculator, we do not need any previous data, sir. Thank you, sir.
So my next question to Dr. Abdurraqib Tushar. In between the extended depth of focus IOL and the trifocal IOL, which one you prefer?
Thank you, sir, for your important and nice question. Sir, as I said in my presentation, the choice of IOL it depends on the particular age of the patient gender, patient occupation, and patient daily lifestyle. If patient is an office executive, like his or her work is during the desk job, I prefer the EDOP IOL. Or if the patient is a reader, like elderly male patient or elderly female patient, he or she wants to read the religious books or to spend time with the newspaper, I prefer for the traditional trifocal IOL. Thank you, sir.
Okay, thank you. And next, last question to Professor Jalal.
Sir.
So if your patient is determined to take a premium type trifocal IOL, but he has a very rigid pupil, so how you will perform the surgery? Rigid pupil, not responding to dilator.
Thank you, sir. Here is the difference is only the pupil. Pupillary dilatation is important. First, I will try with drugs, medicine like
no drug is active. No drug is active because he has a rigid pupil. Maybe posterior synechia is there.
Okay. Then I will use some type of mechanical dilators like Malosian ring or Irish hook or any other form of dilator. I will first place the dilator, then I will do the surgery like usual surgery.
So do you think that in that case, the patient have the postoperative dilated pupil, and does it affect the visual acuity or the quality of vision? If you trace the pupil, yeah.
Thank you, sir.
If you dilate the pupil mechanically,
yes, sir.
If you dilate the pupil mechanically,
yeah, sir. If you use Irish hook, sir, if you use Irish hook, then there is chance of pupil remain dilated after surgery. But if you use Malosian ring, usually there is no change in shape of the pupil. So in that case, I will advocate Malosian ring, use Malosian ring and do the surgery like usual surgery.
Thank you, sir. Thank you for a very nice 3 questions to the 3 presenter. May I ask any other panelists to ask any other question to Dr. Harun Rashid, Dr. Ashraful Haq, or Dr. Deepak Migur? Any panelist?
I have one question to Dr. Deepak Migur. Later after the panelist.
I have a question to Dr. Deepak. If the glare is the problem due to misalignment of the angle of kappa, how would you manage that patient?
Well, it's an extremely difficult situation to get into, sir. You know, most of the time we just want to try to counsel the patient and just see whether it's possible. But if it is not, then there are a couple of options. Either you have to constrict the pupil, find a way to constrict the pupil. If the patient is too adamant, I wouldn't hesitate to exchange the lens and go in for a monofocal lens in this situation.
Thank you, sir. Thank you for your nice question, and thank you, Dr. Deepak Migur. We'll have just 2 minutes time. Is there anybody having questions to?
I have a question. Dr. Kamrul, I have a question to Dr. Ashraf.
Okay, please.
Thank you, Dr. Kamrul Islam Khan. I have a question to Dr. Ashraf. How we can prevent the smudging of the axis marking? Because correct and very sharp axis marking is mandatory for alignment of astigmatism axis. This is on. And second question is for beginners, which axis marking we can practice?
Thank you, sir. Thank you, sir, for the nice question. Basically, the first thing is that when we do the marking, we need to keep the eye dry, because when there is watering or something like that, so ink become little bit, marking becomes smudge. And some surgeon now what they are doing this with the 26G needle, little bit scratch mark for the marking. And we always need to remember that if there is any smudging of the excess marking, we need to keep it again. And for the beginner, the main thing is that we should start with the freehand marking. When we are confident with the freehand marking, we can do anything, slit lamp marking or something. Thank you.
Thank you, Dr. Ashraf. We'll take just one single question to Dr. Harun Rashid. If anybody is asking any question to Dr. Harun Rashid, because we have got only 1 minute time. If nobody has any question, in that case, I want to ask one question to Dr. Harun Rashid regarding selection of patient. What is your comments regarding the extreme elderly and younger patients regarding premium IOL? That is presbyopic correction or something like that.
You're talking about extremely elderly only?
Extremely elderly or younger. Suppose somebody is having a cataract surgery, cataract at the age of 15 or 16 due to any reason.
See, the problem in mostly the elderly, those patients, they love to read books, you know. And particularly in our country also. So I don't mind putting a bifocal IOL, traditional multifocal IOL to them, you know. So, but the thing is that First thing is that, I mean, you should put that lens on the dominant eye and to see how he behaves. I mean, if he doesn't behave well, if he complains about any intermediate vision, then we can put an extended depth of focus lenses on the other.
What about younger people?
Well, the younger people, that depends, you know. Now they have a different options, as Dr. Tushar said, that they love to work on the desk, on the laptops, you know. So distance is about 60 to 66 centimeters. So the Symphony lenses works very good. New Alcon VVT is on the way, just like a Symphony. And the trifocal IOLs of the Zeiss, it has 80 centimeter intermediate distance, and Panoptics has got 60 centimeter, you know. So these lenses are good. And the new lenses on the pipeline right at the moment is available in the European market is.
Thank you very much. Thank you very much, Dr. Harun. That was a wonderful session, lively session. I must thank all the presenters as well as all the panelists, respected panelists, to make this presentation a successful one. And last but not the least, what is most important, we were absolutely within time. Thank you very much. I can end this session. We can switch over to the next session. Thank you.
Thank you.
Thank you.
Our next session is the live surgery session.
Good morning.
Good morning, sir.
Good morning. So,
Chaudhary Sahib.
Yes, how are you, sir?
Hello, sir.
Yes.
I'm fine.
Good. We are about to start the live surgery session, and that was a wonderful session, and a very wonderfully.
Just in time, sir.
So you have done a wonderful job maintaining time. The speaker was excellent. We really enjoyed that. Thoroughly enjoyed the first session, and General Kamrul, you have moderated so well, so it went very well. Thank you, and timing was perfect. So now we will be moving to the next session, that is the live surgery. So,
Assalamu alaikum.
Walaikum
Good morning.
salam.
Can you hear me, Dr. Mahbub?
We can hear you. Can you hear me?
Yeah. Thank you so much. Good morning to all of you.
Good morning.
Honorable panelists, moderator of this session. We are going to do a live surgery of the patient. Can you hear me?
Yes, we can hear you, and we can see you also.
Good morning, Mahbub.
Yes, I welcome all of you in this session. We have two surgeons, Professor Nazrul Islam, who will be doing the first surgery, and there's little change. Dr. Ishtiaq Anwar will be doing the second surgery, and we'll have Dr. Shaukat Kabir as my moderator, co-moderator, and we have three eminent phacosurgeons as a panelist. Dr. Din Muhammad Nurul Haq, I welcome you, and also Dr. Muhammad.
Thank you.
Najmul Islam, sir, thank you for joining.
Dr.
And
Mahbub.
Dr. AKSM Kamaluddin.
Dr. Mahbub, can I say a few words about the OT?
Thank you.
Yes, please.
Okay.
Over to you, Professor
I welcome
Nazrul.
you all in this live surgery session. And it is really exciting that we are doing this surgery today in the RTO 800 3D digital microscope. And it's a new installment only 2 days back in Bangladesh Eye Hospital. Though it's a new technology, but I'm trying to show you because this is a new experience for all of us. And this microscope has very good resolution, very good depth perception. So surgeon can see better. I'm looking straight to the monitor, not to the microscope. Very important. And well, my patient is Mr. Mitro, Sanjeev Kumar Mitro. He is 48 years old. He has having right eye pseudophakia and left eye having early cataract with some PSC. He is diabetic. He has also history of topiramate-induced secondary angle closure glaucoma. So I'm also doing the surgery because of that, so that angle should be open after the surgery. So can I have my side port? So with your permission, can I start the surgery?
Yes. Yes, please.
Thank you very much.
We are looking forward to this. Yes.
Here there is a Callisto aided display here. So I can see my side port, main port, axis, everything here by the Callisto aided display, the overlays. So I'm giving my side port in the left eye is about 80 degrees from my main port.
Professor Nozul sir, we have given the good view of the microscope and the
view. And I'm having Mr. Alamgir with me to assist the surgery, Mr. Munir and other technicians, Engineer Urmil, all of you helping me here. Thank you very much, everybody.
Thank you, sir, for your live commentary.
So I'm giving the intracameral lidocaine a little bit because patient is under topical anesthesia. Now I'm giving some methyl cellulose here. So I'm using the cotton bud to support the eye and doing my 2.4 millimeter keratome at the 30 degree. The triple incision.
Sure. Sir, are you using sir 2.4 or 2.2, sir?
I've given the dispersive viscoelastic here, and now with the aid of Callisto, given the 5.5 millimeter axis overlay, I'm trying to do the axis with the uterator forceps. Okay.
Video চলে গেছে
স্যার ভিডিও চলে গেছে স্যার
ভিডিও চলে গেছে স্যার
Professor Jalal, we cannot see you because there is probably, we lost you. The connectivity is gone.
Okay.
Can
I
we?
am trying.
You
Okay,
please?
thank you.
Sure.
Thank you for the information. I am just connecting.
স্যার জালাল স্যারকে দেখা যাচ্ছে স্যার
Now I want to, yeah. Professor
you want to say Nozul sir, right?
Can you see us now?
Yes.
No,
Yes.
No, not
yes.
We can see.
We are seeing the OT view, but in the
see the monitor
template.
I'm trying to do this section.
Can you have the monitor view, please?
Can you see the fluid wave? Now, depression of the nucleus.
Yes.
Microscope view is not there.
We are showing the external view.
Why?
Okay. So that attendee can understand how Professor Nozul is doing heads up surgery with his 3D glasses on, and we don't have to use the microscope eyepiece.
Okay.
So now I'm going to rotation. Rotation is not essential here. There's already some products is there, but still I'm doing.
Once this is done, we want the microscope views so that we can appreciate the surgery.
Okay. Can I have the five-point piece?
Okay. Now it's okay. Dr. Ishtiaq, now it's okay.
Since Hook.
Professor Nozul sir, please, commentary, please.
The view is gone again. Nothing is said.
We are seeing, sir.
But yeah, Ishtiaq, the
yes, sir.
the microscope view was very clear at the beginning. Now, are you taking the camera on the monitor and showing us this, or it is the internal camera that will come
I
into
am not
focus?
chopping, rather I am making a mechanical crack.
We can't see anything. We can't see anything.
We should see the external view also. Otherwise, it seems that it is a usual phacosurgery, not a 3D one. We cannot appreciate anything.
3D, you will not be able to appreciate because the transmission in our laptop will not be 3D. And we are not using a polarized spectacles also, so that we will not be able to appreciate the 3D. 3D will be only be appreciated by the person inside the OT and at the same time who are wearing the polarized glasses.
You are correct, sir, sir, because we need spectacles and that 3D TV also. For being not in laptop, we cannot
Can I have the
enjoy the 3D effect.
Yes.
Why the nostril surgery is lost? Nothing is seen on the screen.
No, we are seeing, I can see Professor Din Muhammad Hakam
I'm
here.
using the coaxial NA here.
Actually, I am also seeing the video, but the display, it is not continuous. It is
not continuous?
Somehow interrupted.
Saddam, can you see?
Step by step. That is at the first opening of the we start seeing. At that time it was continuous, but now it is interrupted. But as if the frame per second, number of frame per second has been reduced.
Yeah, and also the red reflex that we saw initially is somehow lost.
And maybe this is the
Mr. Chairman, this is the recorded surgery is showing now?
No,
or
it's
this is live?
Live surgery. This is a live surgery.
Live. The pictures are not very clear as you can see in the first time.
Yeah.
And also not continuous.
চোখের অপারেশন হচ্ছে।
Professor Nazrul, you have wonderfully cleaned the particle matter. We could appreciate it.
Now the capsular polish.
Dr. Ishtiaq.
Dr. Ishtiaq, can you hear from us? Dr. Ishtiaq?
Probably he's preparing for the next patient.
Now, Yediba, hyaluronic.
So
now, Dr. Mahu, can you hear me?
Yeah, we can hear you. Yes. Yes.
I'm using the
Professor
cohesive
Nazrul, would you listen to us for a
cohesive
minute?
viscoelastic before giving the lens, because I will implant a toric IOL.
Yeah.
It is better to not to give the methyl cellulose in this stage.
Okay.
Very
Professor Nazrul,
important
can
that
you hear
we
me?
want to remove all the viscoelastic. So it is better to give the cohesive viscoelastic here.
Professor Nazrul, can you hear me?
Lens. This patient IOL axis is 159 degree, and I'm using the Actisoft toric monofocal IOL, hydrophobic IOL. Can you hear me?
We can. Can you hear us?
Can you hear me, Dr. Mahbub?
We can hear you, but one request: the red reflex is gone. Is there any change in the light modality? We cannot appreciate the red reflex
Because
that
it is
initially
sharing
you
from the
when.
other PC, that's why.
Sorry.
You can show by the mobile here. Okay. Now I am implanting the toric IOL. The power is 19.5. Usually I load the lens myself. I feel it is easy. So can I see the overlay of 159, Munir? Okay.
Yeah, this is going on very well, and we can see the lens being implanted. The incision remains same.
No.
Yes, we can see the lens being implanted. And it's gradually unfolding itself. We can see the toric mark on the optic. The leading haptic has gone in the bag. The Professor Nazrul is now placing the trailing.
So I have implanted the IOL now. It is in the 180 degree axis, but it is 20 degree off axis. And after washing, all the viscoelastic, the cohesive viscoelastics I have put, that must be removed everything. Otherwise, this toric IOL can rotate after the surgery.
We can appreciate the toric mark, and
yes, this is in the 159 degree.
Yes, and we can see that all the viscoelastic substance are coming out. And this is one very important step in the surgery, that we have to take out all the viscoelastic substance from the behind the optic, because the chances of rotation will be more if there are viscoelastic substance in the.
Now I see there is no cohesive viscoelastic. So still I'm 5 degree off axis. I'll give my side port here, hydration. Then I will finally align the axis. Hydration. Good. Okay.
So this we can see the toric mark so good. But unfortunately, since we cannot see the digital marker in our screen, we cannot appreciate the position of the axis mark. But we can, I'm sure you're seeing it very well up there in the operation theater.
So one thing, Dr. Mahbub, I want to say that I am showing totally non-marking, that is digital overlay toric surgery. And because Dr. Ashraf already nicely described how to do marking manually by freehand marking, slit lamp marking, he has shown very nicely.
Yes.
So my alignment is still remaining. So now I will actually finally align.
Can we go to the microscope view? We want to see the final alignment. Yes.
Can you appreciate the alignment?
Yeah, we can see
with the three line of the Callisto.
Professor Nazrul, not really, because this is not transmitted.
Can you share the screen, please? Anyone? By the mobile phone, you can show it here. By the mobile phone, you can show it here. Because the Callisto will not come to the PC Zoom. Actually, I'm in the online, just exactly in the line of 159-degree axis alignment now. So I'm tapping over the lens so that it should be touched with the posterior capsule and should not move after the surgery.
Can we focus on the monitor, the camera? Can it go to the monitor so that we can appreciate the
please,
digital
anybody show
marker?
monitor?
Yes, can we focus a little sharper? Yes, this is, yeah, we can see it, but can we have the full view in the screen?
Can you see now?
Yes, we can see, yes, the Callisto mark. What is the degree of placement, Professor Nazrul?
There are some air bubble also, so you're finding many dots. 159 degree. 159. Okay. Can you see the
Callisto we can clearly see the,
exactly over the three dot here?
Yes, the three dots aligning with the three line.
It's nice alignment, sir.
Sorry, there is some air bubble, so I should remove it. Good.
Professor Nazrul, we can appreciate the alignment.
Yes.
Very well done.
eye should not be very tight, just soft. I think that's all for the toric IOL.
Thank you, Professor Nazrul. We are
Thank you
applauding
very
for
much.
you. Well
And
done. Thank you.
I'd like to thank all of you, panelists, moderator, and definitely I'm grateful to BA Chairman, Dr. Mahabran Chaudhary. He has installed this beautiful microscope so that you can see very easily a heads-up surgery. Ergonomics is better. So thank you so much. Thank you, all of you.
Thank you, Professor Nazrul.
Okay. So anything to know from my side, please?
If you have brief comment, please, and then we'll go for the panelists for their comment.
Sound.
Professor Nazrul, can you hear us? Professor Nazrul, can you hear us?
Yes, we can hear you.
Okay, so if you have a brief comment on the surgery, then we'll go for the comment from our panelists. Professor Nazrul, will you unmute yourself, please?
Nazrul, we can't hear you.
We cannot hear.
Unmute.
Okay, now you can hear me?
Yes, now we can.
Okay. I'd like to thank all of you for seeing the surgery, and it was really nice to do surgery in this kind of beautiful microscope, the 3D Zeiss Artivo 800, and the clarity is very good, resolution is very good, and depth perception is very good. So I think, and most important is the heads-up surgery. I look only to the monitor, not to the microscope like this. So I think for the surgeons who are more than 50 years, they need to use this kind of microscope heads-up surgery. It will help us for the ergonomics, for the neck pain and all these things.
Thank you, Professor Nazrul. Thank you so much. And wonderful surgery. Congratulations to you.
Thank you very much.
Thank you. Now, we'd like to have some comment from Dr. Muhammad Najmul Islam, sir. Would you have any comment on the surgery that we have seen, please?
This is the surgery is very nice, and at the same time, give you the advancement of the equipments and techniques which has improved a lot. I have a question with all the panelists and the surgeon, and Nazrul and Professor Jalal also. There are some patients who bought these intraocular implants, say 15, 20 years back, and they have got astigmatism. Now, is there any solution that the patient could get better vision to overcome this astigmatism? Is the question is clear?
The question is clear that this was this was a monofocal lens was implanted.
Yes.
But he has astigmatism.
Yes.
And what can
high
be done?
degree of astigmatism.
It's a high degree of astigmatism. What can be done about this? Okay. Yes. There are two options in my mind. We can explant that and put a toric lens, or we can put a piggyback lens. Only the toricity will be there, but spherical power will be zero. So these are the two options. Another option is to have the LASIK done to correct the astigmatism that is present now. So these are the things that we have in our armamentarium. So Dr. Din Mohammed, do you have any comment on this question, please?
Yes, hello, can you hear me?
Yes, we can hear you.
Okay, I should say that Professor Nazrul has done a wonderful surgery and nicely in front of so many the virtual audience. And I want to add two things. That is, I have never used intracameral anesthetic. I have never used, but today I have seen that the Professor Nazrul used some kind of lidocaine. I think lidocaine he used. So I never use that intracameral anesthetic. I don't require that. And another thing that I always give, after the surgery, I always give intracameral broad spectrum antibiotic like preservative-free Vigamox eye drop or the Oromox as an injection of 1 ml injection. It is a clear yellow colored, isotonic, preservative-free ophthalmic solution. I give 0.1 ml to 0.2 ml intracamerally in every cases now. So it is safer. Thank you.
Thank you.
Thank you, sir.
Next
May I ask some comments?
surgery, sir, whenever you say.
Professor Kamaluddin, sir, can you hear?
Thank you. Yes. Can you hear me?
Yes, sir.
Yes.
Yes, sir. Loud and clear.
Thank you, Professor Nozrul, for your nice and very nice operation. And all the panelists has discussed about this. One thing I can add about the Professor Nozrul's, that is our Nozrul Bhai. His question that Mahbub have described the three procedure, that is the pigtail lens or the toric lens replacement or the LASIK. But the basic thing he has missed, that is, as the patient has operation 20 years back, and if the patient is happy with this and with spectacle correction, we can avoid the hazard of further hazard of surgery. So if the patient is interested for having a free life, spectacle-free life, and take the hazard of the surgery, only then we should advise the patient for a surgery like LASIK or any pigtail or removal and implanting a toric IOL. And I think everything is okay and everything is fine. The one thing is that I think Professor Mahbub, you should try to correct it, that the video that was displayed, it was not, the streaming was not continuous. That is why that was very difficult to understand the stages. So in the next operation, if it can be made a bit clear, I think it is a technical problem, and the technician behind the
Okay,
screen,
Professor Kamaluddin, we will give it a try. And Ishtiaq is ready with the surgery. So shall we move on to operation theater? And Ishtiaq?
Yes, sir. Yes, sir. Can you hear me?
Yeah, we can hear
Yes,
you.
we are hearing.
Please go ahead.
Sir, this is a patient. We are going to use a Johnson & Johnson Technics multifocal lens. And typically what we do here is use a 2.4 knife. So this is a Intrepid 2.4 knife. And the beauty of this thing, as Professor Nozrul said, that we can appreciate all the depth in so much of magnification. না কেন বন্ধ করে দেন ওটা পানিটা মোছেন তো
Ishtiaq, can you show the microscope view?
Yes, we'll just, I usually make a 2 millimeter entry, so it's near about trapezoid, and then make my side port.
It's a nice regular incision.
And then we use Viscot. So this is a dispersive OVD, which gives extra protection to the corneal endothelium. So this is a soft shell technique which was described by Dr. Arshinov. So giving dispersive and then cohesive under that. This is a Callisto that Professor Nozrul sir has shown. I'm going to show something literally different. I use a Rexis marker. So this is a 5 millimeter mark that I make on the cornea and try to do the Rexis below that marking.
Ishtiaq, we could appreciate the mark so well.
And so this goes away once we have given fluid on the cornea.
Okay, that's great. So yes, you're going.
So Callisto is a very expensive thing that all of us cannot afford. So I feel that this is a very good thing while learning, and also once we are experienced, if we do this, because nowadays the ELP, effective lens position, is becoming so important day by day, sir.
It's a nice tool,
Nice tool, yes. Can you center the microscope a bit, please, Ishtiaq?
I'll just finish the rexis and I'll then do the recentration.
Yes, please. Thanks.
Is it centered now, sir?
It can be a little bit.
No, not
it is off-centered, please. Would you look into this? Yes, yeah, a little
so
bit.
Once the rexis is done,
if
we give fluid, we can see that the mark nearly goes away. And then wash away the OVD that is in the anterior chamber before we do hydro and do multi-dissection and multi-quadrant hydro. The lens is not that hard. It's just 1+ or grade 2.
So you have done the excellent rexis and hydro is done. Do you go for rotation routinely?
Yeah, I always try to rotate. And if it's a hard case and it does not rotate, then I will start sculpting and try to rotate. But if it is a soft one and it does not rotate, I don't try to do it again. But this has rotated easily.
It's a wonderful rotation.
So what I do is I have a pre-chop different setting. So I remove the OVD and then I go to sculpting.
Usually you do sculpting, usually.
Yes. And while I do sculpting, I usually do it in pulse mode so that I can reduce the power.
Energy and power.
Dr. Ishtiaq, what would be the grade of the nucleus?
So this would be something like grade 2, sir.
Okay.
So I'll just have a central sculpting and then I go for chopping. And in chopping, vacuum is the main thing that comes into play.
What is the vacuum setting?
This actually depends on the grade of the cataract. Here I have got 350.
Okay.
Yeah. Wonderful chopping. So you can see the chopping and at the same time the complete separation that is so important as well. So Ishtiaq, you're doing great.
Sir, I try to make the chop complete. And if it is not complete, I will not go into rotation.
Okay. And now you're doing the segment removal.
Yes, I have gone to segment removal and I use burst in this while I remove the segments. And one thing that I have started doing is that I try to place the instrument on top of the nucleus so that it does not hit the cornea.
Okay. That's a good technique.
So do emulsification as far as away from the cornea.
At the iris plane and also in the center.
Exactly. And with the new Century machine that has active fluidics, one thing we can do is we can also control the IOP to our desired
What is the IOP
limit.
setting today?
Currently, I think we have something around 40. 40 is the usual IOP that I use. And for the last piece, I also have a different parameter. So I will reduce everything for the last piece.
Okay, that will protect or keep away the posterior capsule from the tip of the handpiece, I think.
There's a little piece that has gone near the incision. So the nucleus material has been
wonderfully
gone down.
removed. Well done, Krishtiak. Very well done.
Wonderful demonstration doing phaco.
I usually do my irrigation aspiration with coaxial, but if I have any issues at any point, I immediately switch to bimanuals. Hopefully I can take the cortex with coaxial. And with this 3D view, I think would be best for a teaching thing, that how we can, at which level we are holding the cortex, it's away from the capsule, and then bring it in the center, and then take that with only vacuum.
This device might help also the residents or for their teaching.
I've got some bubble, I'm going to try to remove it. একটু আলোটার দিকে তাকাবেন বাবা, হ্যাঁ। So, sir, I would just want to know from Professor Din Mohammad, Dr. Mahur Rahman Chaudhary, sir, that do you have any preference to which part of the cortex should be removed first? The subincisional part or the opposite part from our incision?
Professor Din Mohammad, would you like to comment? Unmute yourself, please.
It depends. It depends because if the posterior capsule is floating, posterior capsule is floating or like fluffy, then it's better to take the distal cortex first and then gradually subincisional. Sometimes if this is stable, then you can take from anywhere you can start, no problem. But in case of the floating posterior capsule, no the adhesion with the anterior phase of the vitrea, sometimes the posterior capsule is free and is dancing. So in that case, you should be very careful to taking out the cortical matter.
So this is a Johnson & Johnson lens. This is a multifocal lens of 20.5 diopters with a 4 addition. And I thank AMO and Zeiss for being a sponsor. And we have always been partnered, and they come up with so beautiful things.
Is the addition is +4?
Yes, in Johnson & Johnson it's +4, and different companies have different addition.
Okay.
So hopefully you can see the rings here.
Yes, we can appreciate the rings.
Appreciate.
So personally, I load the lens. I don't know the preference of other surgeons.
Probably we are in the same opinion that we load our lens ourselves.
And while loading this sort of premium lens, we should take care that we should not go over the optics area, rather hold it in the haptics or haptics optic junction.
Exactly.
That's a nice tip for all of us.
And this is a screw type of cartridge. So if I have a push sort of cartridge, I use the wound for delivery. But for this screw type of cartridge, since I will be using both hands, so I have to go inside the eye. And you can see that it goes very easily within the 2.4 millimeter incision that we have created. And I try to go in the bag at a single go.
In this push type, I think it's a better control for introduction of IL.
Yes, because there has been some instances where the push one went too fast and it can cause PCT. The bag is in the lens. Now I'll go for
Wonderfully implanted, Ishtiaq. So now it's only the removal of the viscoelastic substance. Ishtiaq, are you there? Ishtiaq, we are losing you. Anyway, in the meantime, Professor Kamaluddin, do you have any comment on this surgery?
Thank you, Professor Mahbub. Actually, everybody is seeing and they are understanding the quality and the skill of the surgery. But what I want to say is that actually in this new era of post-COVID era of new normal, we all of us are accustoming with the new system, that is the webinar series and everything. But this live surgery, it is actually not, we are accustomed with it in pretty earlier time. So we enjoyed this live surgery as we are enjoying in our early time, that is a pre-COVID period. Today, one thing I think the video display quality, that is the video streaming, it was not up to the mark. So I think next time we should take a lesson from here that the technical part should be addressed. And regarding surgery, I think Ishtiaq has not yet completed, so we can go.
Can you hear us?
What do you say?
Ishtiaq, can you hear us?
Sir, yes, sir, I can hear you. And I would just like to show that the Rexis that has been created with that Rexis marker is excellent and covering all of the optics. And we can see from Callisto also that the lens is in the center. So I'm
not seeing so clearly.
I have done hydrosun. Now I will give intracameral cephasity.
That's fine. May I ask Professor Kamal, Professor? Professor Nozmul, sir?
Actually, coaxial.
Thank you, Dr. Anwar. You have a very nice operation, and thank you, the panelists. One thing I want to congratulate the Bangladesh Eye Hospital so that they have developed a system, and it is good that they have got a 3D microscope also, and this is good for teaching purposes. As Professor Kamal said, this is in post-COVID era, and it will be very useful for the learners at distant places to observe these operations, and if this facility is made available for them in Bangladesh Eye Hospital. With these few words, I congratulate all the organizers, the Bangladesh Eye Hospital, the panelists, and both the surgeons, Professor Nazrul and Dr. Ishtiaq Anwar, for having a beautiful demonstration of surgery. Thank you very much.
Professor Dimo sir, can you say
Okay.
something, sir?
Just one thing. Can you hear me?
Yes, sir. Loud and clear.
Okay. Okay. So I just make one comment on the removal of the last piece. The last piece is the dangerous. The removal of the last piece is dangerous. Another thing, the most of the surgeons actually damage the posterior capsule during the removal of the last piece and also during the irrigation and aspiration of the cortical matter. The cleaning of the cortical matter and the removal of the last piece, these two things is very dangerous and maximum disaster occur during these two things. So my advice, during the removal of the last piece, no need for change of any parameter. Only you can do one thing, you can put the spatula or the dialer underneath the last piece, and then you can take above the spatula, you can take the last piece out. In that case, the posterior capsule never come in touch of the phaco tip.
Sir, can you, sir, adjust the suction is linear mode so that we can control the suction?
Yeah, you can do that. But another thing is that for the cleaning the posterior capsule after the surgery, after the nucleus is removed, you never put the port of the irrigation aspiration tip down. Never. You keep it always up. In that case, you never touch the posterior capsule.
But Professor Nazrul Din Mohammed, do you think that keeping the dialer behind the last segment may harm the posterior capsule, may make trauma on
No,
the
it is
posterior
a
capsule?
blunt. It is a blunt, not sharp. Blunt spatula. I always keep it. No
Yes, spatula is okay, but do you advocate dialer for?
Dialer, the blunt. I have the blunt dialer, round type of blunt dialer, not the pointed one.
I think.
Yeah, Professor Dil Mohammed, that's a nice tip that you have given. At the
Professor
same
Mahbub,
time,
I have a question.
Yes, please.
Actually, this is a question to the surgeons, both the surgeons, regarding the mechanism. That is, when they are operating, they say that this is a good stereoscopic view. But do they see through the eyepiece or with the special spectacle? They are getting the stereoscopic view. And the second question is whether the audiences or the persons attending the OT in the monitor, can they see the stereoscopic view in the monitor, or they need a special spectacle for seeing the stereoscopic view?
Yes.
These are the two questions.
Thank you. So I had the opportunity to start this article, and what we see when we are seeing in the monitor and we have the polarized glass on, we can see the 3D effect and very clearly. And we have, let's say, 5 polarized glasses in the operation theater. So whoever is wearing that and sees the monitor, they'll see the 3D effect. They'll see the 3D effect in the monitor. But when, as you rightly pointed out, if we look into through the microscope eyepiece, this will be same as the other microscope. It will be not 3D effect. But 3D effect will be only be visible, will be appreciated in the monitor only.
And what is the convenience of the surgeon, whether he feel it convenient to do surgery by seeing the monitor with the polarized spectacle, or he will feel confident with the seeing through the eyepiece?
Yeah, we have been using. Yeah, as we have been using the eyepiece from years together, we are used to this. Okay, so this is a little learning curve, and transition is definitely there. But my experience, I would say, the depth of focus and the resolution is so high. You can see it so clearly. Professor Kamaluddin, I will see that if I roughly calculate the distance between the cornea and the anterior capsule, with this 3D effect, it is nearly 3 times higher than the normal depth. Okay, and the depth between the anterior capsule and the posterior capsule, if you see through the 3D, it is nearly 3 times deep. So the safety margin, I feel there's a lot of safety margin to work on. And once you get used to this microscope, probably it will be difficult to reverse yourself and go there, because the depth perception is so much there, and it gives a comfort that, and also safety zone is also the range is higher.
Of course, Dr. Mahbub, I can memorize my past. Once we are confident with cataract surgery with naked eye, with one graphic cataract knife. Then we came to the binocular loop. Then it was difficult to reverse back to naked eye. When we go to the microscope, and now it is difficult to go to the binocular loop to do surgery. So when this new era will start, our surgeons will face it difficult to go to the reverse back to the other one. So that's the world, the science and this technology is advancing. So welcome everything, but regarding Corona, we don't expect that Corona will advance like that. It will retreat.
Okay, thank you.
True.
Thank you, sir.
Yes.
I must
Yes.
congratulate and thank you, Dr. Mahbub Rahman Chaudhary sir, for introducing the newer technology. And I think day by day we also other surgeons are incorporating with this. And I must congratulate Dr. Ishtiaq Anwar for nice surgery and nice demonstration. Thank you, sir. I give speaker to the Professor Mahbub.
Yeah. So this was a wonderful. Thank you, Dr. Shaukat. This was a wonderful session, and we have seen two beautiful surgery. And this is a live surgery is always difficult, but I congratulate Professor Nazrul Islam for doing a wonderful surgery, and also Dr. Ishtiaq Anwar. He is a great surgeon. He has also demonstrated how to do a multifocal lens. And we understand that from the previous discussion on the session first session, that selection of the patient is very important in case of these premium lenses. And we have to have the quality biometry so that the precision and the safety margin is always there. And we had a wonderful discussion, interactive discussion from Professor Din Mohammed, Dr. Professor Najmul Islam, Professor ASM Kamaluddin, and also the surgeon and my co-host, my co-moderator, Dr. Shaukat Kabir, has been very supportive in organizing this conference. And also he was supposed to do the surgery, but somehow he have done an important role in the moderation session. So I thank everybody here, and we have completed this session on time. And I again congratulate the surgeon and also all the panelists and moderator for joining this session. So thanking you, we'll move to the next session. Thank you very much.
Thank you, sir. We are concluding this session. Our next session is Dr. Jahangir Alam Mukut oration. It will be starting within 5 minutes. ঘরে চলে যাবো কিনা এখানে একটু পাওয়ার লাগবে আচ্ছা এই অসুবিধা হ্যাঁ আচ্ছা ঠিক আছে স্যার সুন্দর হচ্ছে স্যার পরের সেশনের মডারেটর মোস্তাকটা আচ্ছা
এখানে শুধু এই যে কজন মডারেটর ওনারাই যাতে থ্যাংক ইউ
আপনাকে টি ব্রেক কে আমাদের
ফ্রেশ লাগতেছে আমি বলতেছিলাম স্যারকে যে আজকে সকালবেলা সকালে মনিটরে উঠতে দেরি হয়েছে
লাইভ প্রোগ্রাম অলওয়েজ স্পিড থাকে, টেনশন থাকে, লাইভ প্রোগ্রাম অলওয়েজ ঝামেলা হয়।
শওকত,
ভিডিও অন অফ করেন।
ডক্টর শওকত,
হ্যাঁ, সালাম স্যার। মোস্তাক।
জি, হ্যাঁ
হ্যাঁ স্যার, স্যার নজরুল স্যার, সালাম স্যার।
শওকত ভাই, হ্যালো শওকত ভাই, আপনি
জি
শুনতেছেন?
স্যার, শুনতেছি স্যার।
শওকত ভাই আমাকে শুনতেছেন? মুস্তাক,
হ্যাঁ শোনা যাচ্ছে।
আমার ইয়েটার সময় কি আমি মাইক্রোস্কোপ ছাড়া কথা বলতে পারি? এটা একটু ঠিক করে দিবে প্লিজ।
আচ্ছা, এটা শেয়ার করব কেমনে?
এখানে চলে আসো, আগে এটা করে দিয়ে যাও আমাকে প্লিজ।
ওটা একটু পরে আসছে, বুঝছেন?
এটা আমি যদি ডিরেক্টলি
ব্যাকগ্রাউন্ডটা আমি দিতে পারি না।
আসসালামু আলাইকুম সবাইকে, শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে স্যার। আমি স্টার্ট করব।
মুস্তাক শুনতে পাচ্ছ? ওকে ওকে, থ্যাংক ইউ ভেরি মাচ, থ্যাংক ইউ। শওকত শুনতে পাচ্ছ?
সাড়ে 11। কখন স্টার্ট করব? টাইম হয়ে গেছে তো স্যার।
You can start please.
স্টার্ট করব?
Yes.
Good morning and welcome to the Jahangir Alam Mukut oration session. Jahangir Alam Mukut was an eminent facu surgeon in Bangladesh and a good organizer. He died on 22nd June 2020. Our prayers and thought for his departed soul. The session will be chaired by Professor M. Nazrul Islam, President, Bangladesh Society of Cataract and Refractive Surgeons. Today's convener is Dr. Muhammad Shaukat Kabir, Secretary, Bangladesh Society of Cataract and Refractive Surgeons. Dr. Mahabur Rahman Chowdhury, Chairman, Scientific Subcommittee, will deliver today's oration. Ladies and gentlemen, now Professor M. Nazrul Islam will introduce Dr. Jahangir Alam Mukut. Please, sir.
Thank you very much, Dr. Mustaq Ahmed. Can you hear me, please?
Yes, sir.
Loud and clear, sir.
Okay, sir. Let me share the slide. Can you see my slide too?
Yes, sir.
Yes, sir.
Just a minute. Assalamu alaikum to everybody. Today's convener, Dr. Shaukat Kabir, our moderator and speaker, orator, Dr. Mahabur Chowdhury, and all the honorable panelists, guests, and delegates. With a very heavy heart, we want to actually say that Jahangir Alam Mukut is not with us. He's so dynamic, our Joint Secretary General, dynamic leader to us. That is really, we feel so sorry to say that we lost him and today we are going to do oration in memory of him. Really, we mourn for him. Dr. Jahangir Alam Mukut was consultant facus surgeon in Bangladesh Eye Hospital and Institute. He was founder director of Bangladesh Eye Hospital, Bangladesh Specialized Hospital, and definitely he was the very right person, founder chairman to think about the Specialized Pharmaceuticals Limited, the UNIDO Pharmaceutical Limited, and formed by all the ophthalmologists of Bangladesh, most of the ophthalmologists of Bangladesh. He is Dr. Jahangir Malkur. We always to see him in the hospital as a consultant like this. But if you look to this picture, Dr. Mukut was a kind of philosopher. All the time he used to think, and he used to give the right comment at the end of a meeting. So this is his picture I find all the time. Even in his village, you can see he is looking something like a philosopher. He born in Gaibandha in Bangladesh. His father is MD Shamsul Alam Pradhan, and mother expired, and she is let Mrs. Zarina Alam. And unfortunately, we lost our friend, our colleague on 22nd June this year. Dr. Mukut graduated from Dhaka Medical College in 1996. He did his Masters of Surgery in Ophthalmology from ANIO in 2009. He worked in many places, including Mujibur Nasai Hospital, in National Institute of Ophthalmology, and also in Dhaka Medical College. In his life, he was really very punctual. He used to do work from morning to midnight. And this is one kind of meeting. He's doing the meeting of the UNIDO Pharmaceuticals in a midnight at Bangladesh Eye Hospital and other places. This is the family of Dr. Jahangir Alam Mukut. He is married with Dr. Shirin Akhtar. She's also a doctor. And they have only one daughter, Zarin Tahiyya Noshin. And Noshin is now reading in the 7th grade now. You can see, so innocent child. And this child lost his parent, lost his father. So unfortunate for all of us. Dr. Mukut used to travel many places with friends, with families. And these are some of the memories in the sea beaches, Cox's Bazar and other places. And we really feel that he was so attentive to the families, to the daughter, to the wife, and he used to go here and there to give the leisure time among his very busy professional time. He was also involved with many organizations in politics, non-political organizations. This is some of the example. He was involved in Dr. Shahid Milan Sangshad from the very beginning, and definitely he used to give the important solutions, important policies to different organizations. Today, he is not with us, but I thank BSCRS, Bangladesh Society of Cataract and Refractive Surgeons, to take this decision that we'll remember him every year in the annual conference by oration. And definitely, we are very thankful. We are giving the oration is given by our chairman of Bangladesh Eye Hospital, Dr. Mahbub Rahman Chaudhary, who was most closest person, closest doctor of Dr. Mukut. And actually, we used to think that he was the right hand of the Dr. Mahbub Rahman Chaudhary, and we lost him. So let Allah subhanahu wa ta'ala grant Dr. Jahangir Alam Mukut Jannatul Firdaus. Let us pray for him so that he will be in the best place in the next time of his life. Thank you so much.
Thank you, Professor Nazrul Islam sir. Our prayers and thought for Mukut's departed soul. Now I invite Dr. Muhammad Shaukat Kabir to introduce today's speaker, Dr. Mahbub Rahman Chaudhary.
Unmute, please. Dr. Shaukat, unmute.
Thank you, sir. Thank you, Dr. Mustak, for giving me opportunity to present my mentor, Dr. Mahbub Rahman Chaudhary. Screen share to করছে
You can see, I can see the screen. I can see the screen.
Dr. Musa, can you hear and see?
Yes, yes. You are audible and
thank you, sir. I must thank you, Bangladesh Society of Cataract and Refractive Surgeons, for giving me opportunity to present my mentor, Dr. Mahabur Rahman Chaudhary. So I starting my presentation. Dr. Mahabur Rahman Chaudhary was born in North Sindhi, Bangladesh in 1955. He completed his MBBS in 1982 from Dhaka Medical College. In 1991, he obtained fellowship, that means FCPS, in ophthalmology from Bangladesh College of Physicians and Surgeons. Dr. Mahabub interested in ophthalmology and started when he was posted as medical officer in ophthalmology in the department of Shohid Sarwardi General Hospital in 1986. He also worked in ophthalmology department of National Institute of Ophthalmology, Sir Solimullah Medical College Hospital, Dhaka Medical College Hospital, while he is in government service. During this period, he felt need for subspecialty training. In 1990, he left government service and joined Mujibunnisa Eye Hospital as a consultant. While attending international conference, he felt that Bangladesh was lacking behind in the field of ophthalmology. So he wanted to bring phaco surgery to Bangladesh. For this, he went for fellowship training in phaco surgery at Raghudeep Eye Clinic, Ahmedabad, under the guidance of his mentor, renowned phaco surgeon, Dr. Abhay Bhasavada, in 1994. Dr. Mahabur Rahman Chaudhary also underwent training in other training centers, facilities for further enhancement of his skills, namely LVPI, Hyderabad, India, Rukmin Eye Hospital, Bangkok, Thailand, and Hashmani Eye Hospital in Pakistan. He became first ophthalmologist to perform phacoemulsification cataract surgery in Bangladesh. In 2004, he, along with other prominent ophthalmologists, co-founded Bangladesh Eye Hospital. Bangladesh Eye Hospital was the first subspecialty based hospital in the country, and he has been the chairman of the hospital since its inception. It was the inauguration ceremony and was inaugurated by His Excellency President, Mr. Jillur Rahman, at October 2014. 2012, in October 2012, it was founded at Shat Masjid Road with the vision of establishing subspecialty eye services throughout the country. Bangladesh Eye Hospital now has 8 branches in Dhaka, Chittagong, and Khulna. Bangladesh Eye Hospital, these are the Bangladesh Eye Hospital branches. In Dhaka, it is at Dhanmondi, Uttara, Shantinagar, Jigatola, and Bonani, and also have other branches like Chittagong, Khulna, and Chittagong, Khulna. Dr. Mahabub always had the desire to groom young surgeons as well as provided quality eye care to the underprivileged. Thus, he formed Bangladesh Eye Trust Hospital, a non-profit eye hospital. Bangladesh Eye Trust Hospital offers postgraduate fellowship training in various subspecialties fields. Its phaco training program has received countrywide recognition, attracting the ophthalmologists from home and abroad, and has become one of the best phaco training center in Bangladesh. He is a high volume phaco surgeon performing more than 1,000 surgery yearly. He has been pioneer in introducing latest and innovative technologies of cataract surgery. He also has a keen interest in establishing a premium IOL in cataract surgery in Bangladesh. He has published papers and presented many forums all over the world. In his ancestral home, he has established a charitable eye hospital in his father's name, as well as he established a school in his mother's name, and currently 700 students are enrolled there. Aside from the ophthalmology, Dr. Mahbub has a passion for poetry. He also played cricket at a national level, mainly during his medical college days. He has immense contribution to the development of ophthalmology in our country. He is a source of inspiration and guidance for all of us. It is a matter of pride for us that we got such an inspiring mentor to guide us. Thank you all for patience hearing.
Thank you, Dr. Shaukat Kobir. Respected audience, I would like to request Dr. Mahabur Rahman Chowdhury. He will give a speech on newer technologies in cataract surgery.
Unshare করব কিভাবে? Stop share.
Stop share. Stop share.
Now unmuted. Okay.
Honorable Chairperson, who is our President as well, Honorable Convener, who is our Secretary General, and our Moderator, who is our Organizing Secretary. Thank you for giving me this opportunity. Dr. Mukut was a brother to me. He was a friend. He was a colleague. He was a partner. He was initially my student, but later he has become my teacher. He was a brilliant surgeon, and he was a brilliant teacher. And he has taught in theory, in practice, and also in hands-on to so many phacosurgeons. And he is credited for producing so many young budding surgeons. I give my respect to Dr. Mukut. And he was always very strong supporter of technology. And the first Lumira 700 microscope that we bought, the phaco machine, Centurion machine, the Lensex machine, he was the main initiator. So the new technology in cataract surgery, the oration that I'm going to deliver is rightly dedicated to Dr. Mukut, who was a strong believer of new technology. Okay. Ashraf, can you move the slide? Okay. And a new technology.
Down left the arrow.
So what we are doing is I'll be talking about a lot of companies, but there's no financial interest. And what is the ultimate goal of our goal is for customized refractive phacosurgery. And for that, we have to become a refractive surgeon rather than a cataract surgeon. And we have to upgrade ourselves. And for each patient, we have to customize planning for each eye, because each eye is different. Each patient is unique. So we have to plan accordingly. And addressing the refractive status of the patient, be it myopia, hyperopia, astigmatism, and presbyopia, we have to take this into consideration. And newer tools that we have to look into, because we need to upgrade ourselves and keep ourselves in the global standard. We have to upgrade in the planning. We have to upgrade ourselves as far as microscope is concerned, phaco machine is concerned. We have to refine our surgery by digital marker. We used to use the suitable IOLs for the patient, and we have to use the latest technology, flax also for the desired patient. Preoperative planning, we have to look into the optical biometry, because the optical biometry is the best way to go, because it, as Dr. Maziba said this morning, it measures the enterial axial length much accurately, and the K reading is more accurate. Measurement of angle kappa can be done through this, and also measurement of the posterior corneal astigmatism can be achieved by this IOL Master 700. So I would recommend that we use the optical biometry for our premium lenses. And as far as the IOL formula is concerned, we need to go for need to go for the Barrett formula. We should not go for the previous formula that we have used, because this is the formula which will give us the best result. And universal formula for all the cases, and toric calculator for astigmatism correction, Barrett True K for the LASIK post-LASIK surgery, and also Barrett True K toric for the astigmatism correction where the LASIK was done, and Barrett RX formula for the piggybacks and IOL exchange. And microscope, we have to have a quality microscope, and Lumira 700 was a brilliant microscope that we have used so far. This is conventionally, this is the best microscope, and we could see, because seeing is things easier. The quality of surgery depends on how well do you see, and from there now we are moving to the digital era, and this is the RTVO 800 3D microscope, where we can see the resolution is much higher, the depth perception is much higher, the light energy that is used is much lower, and it is a great tool for surgery. And the phaco machine is, we are all surgeons are so much dependent on this, but we have to have a quality phaco machine to achieve the quality surgery. Centurion machine is one of the best machine by Alcon, and this system we have control over the better fluidics and IOP control, improve stability of the entry chamber, and that's why minimum surge, it is better cutting availability, and that's why the heat generation is much less. So these are the advantages that we have, and we can do a cataract with hard cataract with this machine so easily. They're giving the best result, protecting the endothelium, protecting the posterior capsule, and that's how we look into our progression. And we can see that this hard cataract can be easily emulsified by the Centurion machine. So we have to have a quality phaco machine to get the best result for our patient. And it's not only Alcon, there's Johnson & Johnson also have the Signature Pro. This is also a very good machine. And similarly, the Bausch & Lomb has the Stellaris Elite machine. These are equally good. So we have to have a best machine to get the best performance. But once the surgery is done, that now it comes to give the best lens. Unless we give the right lens, the visual outcome would not be the best. So what we have in the premium IOLs, the aspheric monofocal IOLs, now we have toric calculation. We have seen 2 surgeries where the astigmatism correction is done, and Professor Nazul has done a wonderful surgery. And multifocal for distance and near vision, we have seen Dr. Ishtiaq perform the surgery, and we have the other modalities for correcting presbyopia. This is trifocal for distance, intermediate, near vision, EDOF for blended vision for distance and near and for distance, and we have toric for in all these lenses as well. And now, so these are the, we are not only dependent on toric, we have J&J where they are giving toric and multifocal lens. We have Carl Zeiss that also giving the trifocal lens, and also the EDOF lens like Etilara. And we've been using this so that we have continuous supply of these lenses, premium lenses. Now, this new lenses that we have been talking about is the Johnson & Johnson has introduced this iHense lens, which gives this is a monofocal EDOF lens, which gives good distance and also intermediate vision. Technosynergy, this is a new combination of EDOF and multifocal lens. This has been introduced in UK market and is not still available in our country, but we are looking forward for this introduction of this lens in Bangladesh. And with the Alcon similarly has bought a IQ VVT lens, which is an EDOF wavefront technology lens, and it doesn't have the rings that we traditionally see in case of multifocal and trifocal lens. So the halos and glares is much less in this lens. And digital marker also is, and for the refinement of the surgery, we have this use of variant by Alcon and also Callisto by Jais for planning the incision, capsulotomy, IOL, toric IOL, and also for the centration of presbyopia IOLs. So this is we can see the mark, we can see the arrows, and we can see the incision mark where to place, and also we can see the rexis. And this is the surgery that I have done day before yesterday while using this Artivo 800 microscope. With this Callisto is there. So this gives us a very good vision and also quality. And we can see the toric lens is being placed, and we can see the toric marker, and this is being with alignment with the lens that we have seen. So these are the variant. We can see the incision mark, where to place the incision mark, so that we don't induce any astigmatism. And the rexis is also can be done by variant as well. So we have the opportunity to use this, and the toric marker also can be used. And also for the centration of the lens, we can use this. And these are the things that gives us quality vision. And we have been talking about the femtosecond laser-assisted cataract surgery, LensX, and this is something that we have been using for quite some time. It's not really a new technology, but definitely a technology which we are looking forward in other centers also in Bangladesh. And NIO also has a flex opportunity, and so do Harun Eye Foundation. So we are constantly striving to remain at the global standard, and so that we can proudly say that whatever you'll be getting in Singapore or in London or New York, we can proudly say this is also available in Dhaka. So this is our pride, that we take this technology to upgrade ourselves, to upgrade ophthalmology of Bangladesh, so that we are at par with the global standard. And since we can see this and this rexis is being done here, and this in difficult situation like white cataract, and also difficult situation where there is posterior polar cataract, and especially in subluxated cataract, where the doing the rexis is difficult. With this femtosecond laser, it becomes much easier and very safe. So this technology definitely helps us in many situations. The energy that is used in flex is lower than the conventional phaco, and this, as I've said, these are the difficult situation. The life becomes easier for us in case of this, while using this latest technology. And latest technology, we want to incorporate this technology in our cataract, in our practice, and this is how we remain up to date. This is how we remain at par with the global standard. And I proudly say ophthalmology is of global standard, and many centers and many surgeons are brilliant surgeons. They are global standard surgeon, and we are proud of them. And now, how do we incorporate this expensive tools, machines in our practice? And it is for a solo practice, it becomes very difficult. It's difficult. So it is the group practice where you have multiple user, and if you have multiple user, that becomes, it can make it viable. And group practice is one of the best way of incorporating incorporating new technology in our practice, and that's how we remain at global standard, at international standard. But I want to thank Dr. Mukut, who has helped us, shown path for new technology in our practice, in our institute. And we promise, Mukut, we will follow this, the path that you have laid, to incorporate new technology in our institute, in our practice. And Mukut, wherever you are, you guide us from there so that we can take the right decision and follow the path that you have laid down. Thank you very much, Mukut. Thank you all my participants for giving me this patient hearing. Thank you very much.
Thank you, sir, for your wonderful delivery on newer technology in cataract surgery. We are at the end of this session. Now I invite Professor Mohammad Nazrul Islam, President, Bangladesh Society of Cataract and Refractive Surgeons, to conclude the session.
Thank you, Dr. Mushtaq. Thank you very much. It was illuminating presentation by Dr. Mahbubur Rahman Chaudhuri, and he's actually the right person to talk on this as an oration of Dr. Mukut. And he has rightly said, as Mukut desired, we are going in the right path to have the different new technology in our practice, especially in Bangladesh Eye Hospital and Institute. Dr. Mahbubur rightly said, we don't have to go to Singapore, London, or New York. We have all technology, the latest technology, the latest Centurion, the Plex, the RTO 800, all the newer technology, Callisto, Barion, everything is here in Bangladesh. So we are really proud. At the same tone of Dr. Mahbub, I like to say, Mukut, you will be happy to know that we did not forget you. We remember every time, every year, and we are going as per your suggestion, as per your guideline. Thank you so much, Mukut, and thank you, Dr. Mahbub Chaudhuri, as giving the oration. Thank you.
Mukut is always in our heart. Thanks to all for patience hearing. Now we move on to next session. Our next session is inaugural session. Thank you all.
Thank you.
Thanks to all for patience hearing. Now we move on to next session. Our next session is inaugural session. Thank you.
ইনোগ্রেশনে 30 এর আগে শেষ না? তারপর তো
Okay. Fordin is our panelist, so they should be in. Our madam already joined. Madam, welcome. Madam, unmute, please, madam. Unmute, please.
মাহবুবের
welcome to madam.
থ্যাংক ইউ মাহবুবের লেকচারটা শুনলাম, খুবই ভালো।
Thank you. Unmute.
আসসালামু আলাইকুম ম্যাডাম।
ওয়ালাইকুম সালাম। কেমন আছো তোমরা? কেমন আছো মুস্তাক?
ম্যাডাম ভালো আছি।
স্যার জয়েন করতে পারছেন?
ম্যাডাম, থ্যাংক ইউ ফর আমার লেকচারটা শুনেছেন, আমার খুব ভালো লাগলো।
হ্যাঁ, তোমার লেকচারটা শুনলাম, আর তোমার মেয়ে তো সারাক্ষণই আমাকে মেয়ে জামাই এনগেজড করে রাখে, ওদের মধ্যেই তোমাকে দেখি।
আপনার কাছে ওদের দিয়ে দিয়েছি।
আমার কাছে দিয়ে দিয়েছো না? খুব ভালো। তুমিও আছো, তোমার ভিতর থেকে ওরাও আছে।
থ্যাংক ইউ সো মাচ।
আসসালামু আলাইকুম ম্যাডাম। আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম সালাম, এসে গেছো? আছোই তো?
জি, শুধু ওই যে শরফুদ্দিন স্যারের জন্য একটু ওয়েট করতে।
না, কোনো অসুবিধা নাই।
ফোন দেয়া হয়েছে? ফোন দেয়া হয়েছে? একটু ফোন দাও কাইন্ডলি, শকত প্লিজ একটু ফোন দাও।
মাজিবা আজকে খুব সুন্দর লাগছে।
থ্যাংক ইউ ম্যাডাম।
মাঝবা সকালে লেকচার দিয়েছে ভেরি
তোমরা
ভেরি
এমনি
নাইস।
সুন্দর, সুন্দর বাচ্চা মেয়েরা তো এমনিতেই সুন্দর ফুলের মতো।
Dr. Majiba, I think only Professor Sharfuddin is left, so he's joining. Let us start because he will talk later on. So can I request you, the moderator of the session, Dr. Majiba, to start the session because we have time constraint.
Thank you, sir. So now we are going to start the inauguration session. Respected delegates, I welcome you all to the inauguration session of the 5th Annual Conference of Bangladesh Society of Cataract and Refractive Surgeons. This is a bit different because this is a virtual conference taking into account the current situation, but we have tried to give a flavor of the physical conference here. And this is a day-long conference starting at 9 a.m. to 9 p.m. and I welcome you all to stay with us. And it's our honor to have with us as chief guest, Professor Ava Hussain, Madam. Thank you, Madam, for being with us. She is the President-elect of Asia Pacific Academy of Ophthalmology and advisor of Ophthalmological Society of Bangladesh. We also have with us as special guest, Professor Sharfuddin Ahmed. He will be joining very soon. He is the President of OSB as well, Chairman of Community Ophthalmology of Bangabandhu Sheikh Mujib Medical University. We have with us Professor M. Nazrul Islam, President of Bangladesh Society of Cataract and Refractive Surgeons, Dr. Mohammad Shaukat Kabir, Secretary General of BSCRS, and Dr. Mahbub Rahman Chaudhry, Scientific Committee Chairperson of BSCRS. Thank you everyone for joining us. So we are going to start. At first, I would like to request Dr. Mahbub Rahman Chaudhry, Scientific Committee Chairperson, to say a few words.
Honorable Chief Guest, my teacher, Professor Ava Hussain, and it's always honored to see her, and whether it is virtually or physically. And it's much charming when I see the smiling face of my teacher physically when we meet. And unfortunately, Dr. Sharfuddin, my friend, he has also joined in. And Sharfuddin, thank you for joining in. And he's all been together. And we graduated from the same year in the undergraduate. So we have been friends since our student life. So thank you for joining in. And my president of this organization, Professor Nazrul Islam, he is a dynamic person. Under his leadership, we have done so many webinars, and while he was in the society in different capacities, he has shown the path of leadership, and he has taken the society to a higher level. Dr. Shaukat Kabir, the young dynamic leader, and we're really proud that he is our secretary, and at the same time, he is also taking a big step and helping the young ophthalmologists to take this path of upgrading the ophthalmology in Bangladesh. This conference is virtual, but virtual has an advantage. We usually, when we have physical conference, we used to have 1 or 2 or 3 foreign faculties. Now we have more than 30 foreign faculties joining us in this session. So this is an opportunity also that the COVID has given. So this is an international flavor. And not only that, now we have 3 international societies joining hands with the Bangladesh Cataract and Refractive Society surgeon. And these are, number 1, we have APSCRS as a society, partner society. We have Intraocular Implant Society of India. We have the Phacomentors from USA. So these are 3 sister organizations who has joined and given more importance to this session. At the same time, we have been, as a society, we have been trying to upgrade the science, take their science forward, and we have been teaching our youngsters, and some of them are better surgeons than us. So this is the achievement that we have. And at the same time, we have been promoting phaco surgery in the district level also. So this is something that we have given quality surgery to our patient in district level also. And also we are upgrading the use of premium lenses. And when we see that our young doctors, young ophthalmologists, young surgeon, a brilliant surgery, and at the same time implanting a toric lens and presbyopia-correct lens, this gives us a pride. And this is the pride that Bangladesh Society of Cataract and Refractive Surgeons takes. And we are very proud as a team, and we'll take the ophthalmology forward in Bangladesh. Thank you very much.
Thank you so much, sir. Now we will hear a few words from Dr. Mohammad Shaukat Kabir, Secretary General of BSCRS.
Am I audible, Mahajiba?
Yes, you are audible.
Thank you, Dr. Mahajiba, for giving me opportunity to say something. Assalamu alaikum. Good afternoon. Dear colleagues, delegates of ophthalmic community, guests, and presenters of different topics, welcome to the virtual and colorful event of annual Scientific Conference of Bangladesh Society of Cataract and Refractive Surgeons 2020. It was my great pleasure and definitely a delightful honor to welcome you all. The participants includes the guests, learners, teachers in today's one-day virtual deliverance of knowledge. Though the flavor of early winter is buzzing through our part of the world, as this is a virtual gathering, we mostly will miss the essence of the winter day, but presence of all of you will certainly pour colorful festive mood throughout the webinar. It is our great wholehearted pleasure to have our today's chief guest, Professor Abha Hussain Madam, President-elect APAO, is also an universal teacher of the whole ophthalmic community of Bangladesh around us. Her enthusiasm, pace give us a strength to hold today's academic program, which we hope that all participants will enjoy and learn new things in the field of cataract and refractive surgeries. Also, the presence of special guest Professor M.D. Sharfuddin Ahmed Sir, President of our Guardian Society, Ophthalmic Society of Bangladesh, definitely giving us a courage of holding this big event in its colorful height. Today, a whole day of learning in a festive mood will be delivered by our national speakers as well as international teachers of this arena, like Dr. Ron, Professor Graham Barrett, Professor Abhay Bhasabhada of APSCRS, and from IIRSI, Professor Mohipal Shasdev, Dr. Professor D. Ramamurthy, Dr. Parthu Vishwas, Dr. Amar Agarwal, Dr. Susan Jacob, and different speakers from the faculty mentors like Dr. Ivo Ferreira Rios, Dr. David Lockington, Dr. Pradip Mohanto, Dr. Rohit Shetty, Dr. Dan J. Reinstein, and so on. We are very much thankful to them. We are confident that giving us space by these help teachers of the ophthalmology will not only enrich our knowledge, but also learning many tips, loops, and corners of the subject by practicing professionals, but also the students, new learners in the cataracts and refractive surgeries. I must very much thankful to our Chairman Scientific Subcommittee, Dr. Mahbub Rahman Chaudhary and his team, especially Dr. Ishtiaq, Dr. Mahajiba, Dr. Ashraf, Professor Nazmul Islam Sir, Professor Jalal, Professor Din Mohammed, Dr. Mushtaq, Dr. Tushar, Dr. Kamrul, and all other members for their endless support to make this conference most successful one. Our President, Professor M. Nazrul Islam Sir, is also our main driving force. His full-time supervision and guidance make the annual conference successful. It is worthwhile but not the least to thanks the sponsors, Aristovision, Popular Pharmaceuticals Limited, General Vision Limited, SP Trading House, and Option Pharmaceutical Limited for their platinum support, and Ibn Sina and Jais Meditech for their gold sponsorship. Without their wholehearted support, advice, and supervision, this big event would have been quite impossible. Thanks to them, on behalf of BSCRS, we are also invited to visit our exhibition hall and see these stalls. I also like to thank to our media partner, Virtual MNC, especially Mr. Shubhankar and Mr. Nimit for their wonderful support and advices. Thank you all participants, teachers, guests for making this event meaningful. I wish this annual conference a grand success. Thank you all.
Thank you so much. Now I would like to invite our special guest, our head President of Ophthalmological Society of Bangladesh, Professor Sharafuddin Ahmed sir, to say a few words.
Thank you very much. I am very much delighted to be with you, the President of Bangladesh Society for Cataract and Refractive Surgery, Professor Dr. Nazrul Islam, Chairman Scientific Committee, my friend, Professor Dr. Mahbubur Rahman Chaudhry, our chief guest, who is always with us, and he is our encourage, he is our guardian, Professor Abha Hussain, President-elect Asia Pacific Academy of Ophthalmology, and Shaukat Kabir, who is the Secretary General of this society, that is Bangladesh Society for the Cataract and Refractive Surgery, moderator Mahajiba, and others whose name was uttered by Dr. Shaukat, that who has made this conference a successful one. I thank all of them. It's my proud privilege to be with you as a president of Ophthalmological Society of Bangladesh, because I think among all other sister organizations, Bangladesh Society for the Cataract and Refractive Surgery, which was guided previously by Din Muhammad, Professor Dr. Mahbub Rahman Chaudhry, and Dr. Nazrul, all are doing very good, and they are making our new surgeons, and they have discovered the new dimensions. Yesterday, I saw about your 3D. I am very happy that Bangladesh is not beyond any other situation of the world. I say sometimes in TV talk show that ophthalmology is the only subject who can at least compete with other parts of the world where we can do everything. And you have started, and this society is giving training to the young ophthalmologists, and I hope this young, once upon a time we thought, Professor Nazmul Islam sir was telling that Professor Harun was telling, after Nazmul Islam, who will come to operate his eyes? Nowadays, I think the young ophthalmologists who are the phaco surgeon better than us, and I hope we are very much safe to them, and we can operate our eyes to them. So this society has come up in such a way that they have trained up the young ophthalmologists. They have given the new instruments, that is artificial intelligence, also come to our country in different sectors. And also Bangladesh Eye is working along with this Cataract and Refractive Surgeon Society in the different parts of the country where this training is also going on. I thank to all the surgeons of cataract surgeons of the country who are working and who are the members of Bangladesh Society for the Cataract and Refractive Surgeon. I hope there are a lot of backlog in our country. You know, about 7 lakh backlog, and still 70,000 per year new cataract patients are coming, but the surgeons are not much more. There are 1,200 or 1,300 ophthalmologists, but all are not the surgeons. So we should make all at least SIC surgeon and phaco surgeon, which will at least reduce the backlog of our country, and they will prevent the blindness of our country. I hope we will come up, and if we want to help the government, they through their national eye care, they can also make the eye camps. They can also give some of the ideas about how the patients during this COVID period can come from the rural areas, from the different segments, even from the districts and upazilas. And if we can make them aware, they will come to the hospitals in division or in the tertiary level, and we can also give much more time other than our office time. We can give service to them for reducing our backlog. I thank all the national and international lecturers who are participating in this conference, and the organizers, and also some of our partners who are always becoming the patron, and they are supporting all the conferences of our country. I thank all of them, and I hope this conference will be a very successful one, and that will help in enriching our knowledges among the young ophthalmologists, residents, and also our senior ophthalmologists. They can also renew themselves through these conferences, these scientific seminars. With these few words, I hope this conference will be a very successful one. Thanks to all. Thank you very much.
Thank you so much, sir, for your excellent advice. Now it's my honor and privilege to call Professor Ava Hussain, Madam, whom I say that it's not only my teacher, but also teacher of my teachers, and President-elect of Asia Pacific Academy of Ophthalmology. Madam, would you please say a few words?
Thank you, Majiba. Thank you. আমার মনে হয় আমাকে প্রফেসর নজরুল আগেই বলেছিল যে এই সেশনটা অ্যাবসলিউটলি ফর বাংলাদেশ, আমাদের কোনো ফরেন ফ্যাকাল্টি এর মধ্যে থাকবে না। কাজে আমার মনে হচ্ছে যে আমি প্রফেসর শরফুদ্দিনের ব্যাকগ্রাউন্ডে স্মৃতিশোধ দেখে আমি লোকটা সামলাতে পারছি না যে আগামী মাসে আমাদের বিজয়ের মাস, কাজেই আমি বাংলায় কথা বলবো, এবং এখানে যারা আছে সবাই বাংলা ভাষা ভালো করে বুঝতে পারবে সেজন্য। আজকে বাংলাদেশ সোসাইটি সভাপতি কি পারমিশন দিচ্ছে?
অবশ্যই অবশ্যই ম্যাডাম, আমি সেটাই বললাম, কোনো অসুবিধা নেই ম্যাডাম, প্লিজ প্লিজ।
বাংলাদেশ সোসাইটি অফ ক্যাটারাক্ট এন্ড রিফ্র্যাক্টিভ সার্জনস এর উদ্বোধনী অনুষ্ঠানের সম্মানিত সভাপতি, স্নেহস্পদ সভাপতি প্রফেসর নজরুল ইসলাম, আমার অনেক প্রিয় ছাত্র, আজকের অনুষ্ঠানের বিশেষ অতিথি আমরা সবাই জানি অপথলমোলজিক্যাল সোসাইটি অফ বাংলাদেশের সভাপতি, বঙ্গবন্ধু বিশ্ববিদ্যালয়ের চেয়ারম্যান, অপথলমোলজি ডিপার্টমেন্ট এবং সাবেক মহাসচিব বিএমএ, এছাড়াও ইন্টারন্যাশনাল প্ল্যাটফর্মে অনেক তার কার্যকলাপ, সার্ক একাডেমি অপথলমোলজির ভাইস প্রেসিডেন্ট এবং আমার এশিয়া প্যাসিফিক একাডেমি অপথলমোলজির রিজিওনাল সেক্রেটারি বাংলাদেশের এবং কাউন্সিল মেম্বার এপিও। আজকের অনুষ্ঠানে আরো উপস্থিত আছে আজকের এই সমিতির মহাসচিব ডক্টর শওকত কবির, আর আছে মাহবুবুর রহমান চৌধুরী, আমার অনেক প্রিয় ছাত্র, আজকের অনুষ্ঠানের সায়েন্টিফিক কমিটির চেয়ারম্যান। আমি একটু আগে ওরেশন লেকচারটা শুনলাম, এত ভালো, এত সুন্দর, যে সত্যি কথা এটা, আমি সবসময় এই কথাটা বলি যে আমাদের যারা আছে বর্তমান প্রজন্মের যারা এগিয়ে যাচ্ছে, তারা একসাথে গ্লোবালি এমন কোনো দেশ নাই যার সাথে একই ব্যানারে, একই স্টেজে দাঁড়িয়ে একই সুরে কথা বলতে পারে না, কাজ দেখাতে পারে না। তারা তাদের নিজস্ব যে সার্জারি, নিজস্ব যে কাজ, নিজস্ব যে রিসার্চ, সবকিছুই শেয়ার করতে পারে। এই অবস্থানে আছে বাংলাদেশের প্রতিটি আজকে যারা কম্পিট করবে। এখানে বহু ফরেন ফ্যাকাল্টি, আমি শুনলাম যে 30 জন আছে, আমিও দেখেছি, সকাল 9টা থেকে শুরু হয়ে রাত 9:30 পর্যন্ত। কাজেই কয়েকদিন আগে সার্ক একাডেমি অপথলমোলজির ওয়েবিনারে প্রফেসর রাজবর্ধন আজাদ, ওনাকে সবাই চিনেন, সার্ক একাডেমির মহাসচিব, এবং এশিয়া প্যাসিফিক একাডেমির ফর্মার প্রেসিডেন্ট ছিলেন। উনি সেদিন জিজ্ঞেস করছিলেন, বলেন তো কখন বাবা এবং শিক্ষক সবচেয়ে বেশি খুশি হয়? তো আমি তখন বললাম, যখন আমাদের কিডসরা আমাদের ছাড়িয়ে চলে যায়, শিক্ষককে ছাড়িয়ে যায় এবং বাবাকে ছাড়িয়ে যায়, তখনই সবচেয়ে খুশি হয়। সবাই এক বাক্যে বলল যে কথাটা ঠিক, কথাটা ঠিক। প্রফেসর হারুন আজ নাই, প্রফেসর মতিন স্যার নাই, প্রফেসর জলিল স্যার নাই, প্রফেসর মোবারক স্যার আমাদের ছেড়ে চলে গেছেন, আরো প্রফেসর শরীফ স্যার, আমাদের এই প্রজন্মের অনেকেই তাকে ওনাদের দেখেন নাই, কিন্তু ওনাদের পথ চলার সাথে ওনাদের প্রতিটা ফুটস্টেপে আমরা এগিয়ে এসেছি। আমাদের দেখে আমাদের পরে আমাদের ছাত্ররা এগিয়ে আসতেছেন এবং তারা আমাদের চাইতে অনেক উপরে আছে। আমি খুব প্রাউড ফিল করি এবং বাংলাদেশের অস্তিত্ব, বাংলাদেশের সায়েন্টিফিক প্রোগ্রাম এবং প্রতি বছরেই এশিয়া প্যাসিফিক একাডেমি অপথলমোলজি শুধু না, আমেরিকান একাডেমি অপথলমোলজি, ইউরোপিয়ান সোসাইটিতেও পর্যন্ত বাংলাদেশের প্রতিটা ছেলে আমার মনে হয় এবং মেয়ে, তারা খুবই ভালোভাবে ওখানে অধিষ্ঠিত হয়ে গেছে এবং ভবিষ্যতে আরো হবে, এই আশা ব্যক্ত করি। আমি সব সময় করি, আমার সব সময় একটা ইচ্ছা, আমি যতদিন বেঁচে আছি আমার মনে হয় আমার এই ইচ্ছাটা যদি আমি সফল করে যেতে পারি, যে আমি চোখে দেখতে পারি, আমি শুনতে পারি যে আমাদের বাংলাদেশ থেকে সব জায়গায় ছড়িয়ে ছিটিয়ে সব জায়গায় আছে, আমেরিকাতে আছে, ইউরোপের কান্ট্রিতে আছে, এশিয়া প্যাসিফিকে তো আছেই, এবং আফ্রিকা এবং অস্ট্রেলিয়া সব মহাদেশে ছড়িয়ে আছে। তো কাজে এইটা যদি আমি আরো বেশি আগামী 2 বছর আমার টেনর থাকবে, আমার মনে হয় যে ওই সময়ে আমি বাংলাদেশের আরো বেশি সবাইকে আশা করব যে সবাই যেন পার্টিসিপেট করে। এই রিসেন্টলি আমরা দেখতে পাচ্ছি বাংলাদেশ ইয়াং অপথলমোলজি সোসাইটি একটার পর একটা, ওদের জন্ম খুবই কম সময়ে, 2 মাসের কিছু উপরে, কিন্তু ওরা এত সুন্দরভাবে একটার পর একটা ওয়েবিনার করছে যে সত্যিকার অর্থে আমরা প্রাউড ফিল করি যে যেভাবে অন্য ফরেন ফ্যাকাল্টি যে কথাটা বলছে তার চাইতে আরো অনেক সুন্দর এক্সপ্লানেশন দিয়ে দিচ্ছে আমাদের ফ্যাকাল্টি, আমাদের পোস্ট ফ্যাকাল্টি। কাজে আমরা ভীষণ রকম ভাবে প্রাউড ফিল করি। প্রফেসর শরফুদ্দিন থাকে, প্রফেসর হজরত আলী, প্রফেসর মিজানুর রহমান, প্রফেসর শকতারা শাকুর, প্রফেসর ডক্টর মিজান, ডক্টর তারিক, এবং আমি অনেককে দেখেছি যে এইখানে বসে প্যানেলিস্ট হিসেবে অনেক ভালো কথা বলে গেছে তাদের সম্বন্ধে। তারা যারা প্রেজেন্টার, খুবই ভালো প্রেজেন্টার। তো কাজেই এই অবস্থায় তার মানেটা কি, ডক্টর মাহবুবুর রহমান চৌধুরী, প্রফেসর নজরুল ইসলাম যে লেভেলে আছে তাদের পরের লেভেলটাও অনেক উপরের দিকে উঠে গেছে। কাজে আমরা আশা করতেই পারি যে বাংলাদেশ আস্তে আস্তে একটা স্টুডেন্ট আমাদের পাশ করার পর থেকেই, কালকেও বাংলাদেশ একাডেমি অপথলমোলজির একটা মিটিং ছিল, সেই মিটিং এ আমি দেখলাম প্রত্যেকের মনের ভিতরে একটা আকর্ষণ যে কি করে অপথলমোলজিস্ট বাড়াবে। দিনে দিনে অপথলমোলজিস্ট কমে যাচ্ছে, সাব স্পেশালিটিতে ঢোকার মতো এত বেশি হচ্ছে না। কাজে কি করে বাড়বে, এই চিন্তাধারাটাও যেন সব সোসাইটি থাকে, সবাই যেন ওইভাবে ট্রেনিং দেয়, সবাই যেন ওইভাবে কাজ করে। এই বলে আমি সবার কাছে আকুতি জানাবো যে প্রত্যেকটা সোসাইটি, আমাদের মাদার সোসাইটি ওএসপি তো আছেই, প্রফেসর শরফুদ্দিন যেটার কর্ণধার, এবং সাথে আছে আমাদের প্রফেসর আব্দুল কাদের, ভীষণ ডাইনামিক লিডার দুজনেই। কাজেই আমরা চাইবো তাদের ছত্রছায়ায় যেন এই সবগুলা, যে এই মাত্র বললো সিস্টার অর্গানাইজেশন, আসলে ওইভাবে যদি অঙ্গাঙ্গিভাবে কাজ করে এই সিস্টার অর্গানাইজেশনরা, তাহলে অনেক বেশি, আরো বেশি আপলোড হবে, আরো বেশি আপডেট হবে, এবং অপথলমোলজিস্টের মান অনেক বেশি অনেক অনেক গ্রেটার হাইটে উঠে যাবে, যেটা দেখতে গেলে আমাদের ঘাড় অনেক উঁচু করতে হবে। আমরা সরাসরি তাকিয়ে সেটা উপলব্ধিও করতে পারবো না, দেখতেও পারবো না। কাজেই আমার মনে হচ্ছে যে আমরা যেন ওইভাবে চলি। সোসাইটি, প্রত্যেকটা সোসাইটি অনেক ভালো কাজ করে। ক্যাটারাক্ট অ্যান্ড রিফ্র্যাক্টিভ সার্জনস তারা কয়েকটা ওয়েবিনার করেছে, আমিও ছিলাম, কিন্তু আরো বেশি পার্টিসিপেন্ট যাতে আসতে পারে, কথা বলতে পারে, বিশেষ করে যারা নতুন নতুন টেকনোলজি কাজ করছে, শিখছে, তাদেরকে নিয়ে এসে কাজ করানো, এবং ফরেন ফ্যাকাল্টি আজকে যারা আছে তাদের বক্তব্য বিষয় অবশ্যই অনেক বেশি উপকৃত হবে আমাদের রেসিডেন্ট, আমাদের জুনিয়র অপথলমোলজিস্ট, আমাদের জুনিয়র যারা এই সোসাইটির মেম্বার। এবং এই সোসাইটির মেম্বার আমার মনে হয় সকলেরই হওয়ার কথা, কারণ ক্যাটারাক্ট ইজ দ্য ব্রেড অ্যান্ড বাটার অফ অল। এইটা পারে না এবার এটা করে না এরকম নাই, খুবই অল্প সংখ্যক আছে যারা শুধু তাদের সাবস্পেশালিটি নিয়ে থাকে, হয়তো ক্যাটারাক্ট করলো না, কিন্তু এরকম সংখ্যা খুবই কম। শুরুতেই হাতে খড়ি দিতে হয় ক্যাটারাক্ট দিয়ে, এবং ফেলোশিপে এরকমও আছে যে মেজর অপারেশন, মাইনর অপারেশন 100 কেস সাবমিট করতে হয় বিফোর এক্সামিনেশন। তো কাজেই এই জিনিসগুলা মাথায় রেখে আমরা মনে হয় আজকে এই সকাল থেকে শুরু হয়ে যাওয়া টাইম, অবশ্য আমি অনেক নিয়েছি। আমাকে প্রফেসর নজরুল কালকে বলছিল যে ম্যাডাম একটু নিতে পারেন, কারণ পরে তো একটু গ্যাপ আছে, আমরা মেকআপ করে নেব। আর আমি বাড়াবো না, আমি অলমোস্ট 12:30টায় এসে গেছি। আমি ধন্যবাদ জানাচ্ছি প্রফেসর নজরুল ইসলাম, আমার অনেক, আবার বলছি, প্রিয় ছাত্র, আমার স্পেশাল গেস্ট। সে তো সব সময়, আমি গতকালকে ফিজিক্যালি দেখলাম অনেক মাস পরে, কিন্তু ভার্চুয়ালি আমরা সব সময় একসাথে থাকছি, এবং দেখে যতটা ফিজিক্যালি ভালো লাগছিল, অনেক ইয়াং, অনেক সবাই বলছিল যে অনেক গ্ল্যামার হচ্ছে আমাদের স্পেশাল গেস্টের। আমার কাছে মনে হয় ভার্চুয়ালি আরো বেশি গ্ল্যামারাস দেখতে লাগে। ইটস এ ভেরি গুড নিউজ। ডক্টর শকত কবির সত্যিকার অর্থে লিডার বলতে এই সোসাইটি, আমার মনে হয় হার্ট অফ দি সোসাইটি, অনেক কাজ করে, অনেক সুন্দর কাজ করছে। এবং আমাদের ছোট্ট মেয়েটা মাজিবা রহমান মডারেটর, খুব সুন্দর মডারেট করে সব জায়গায়। সব আগে ছিল নুজহাত আমাদের মডারেটর একমাত্র, তখন আমরা শুধু দেখতাম, কিন্তু এখন দেখছি যে না, অনেক অনেক উঠে এসছে এবং অনেক ভালো করছে। কাজেই আমি সবাইকে অনেক ধন্যবাদ জানাচ্ছি যারা আছে। আমি যদিও দেখতে পাচ্ছি না, কিন্তু পার্টিসিপেন্ট দেখলাম 22 জন আছে। আমি সবাইকে অনেক ধন্যবাদ জানাচ্ছি, অনেক বেশি ধন্যবাদ জানাচ্ছি, অনেক আশীর্বাদ, অনেক দোয়া সবার জন্য, যাতে সবাই এগিয়ে আসতে পারে, বাংলাদেশকে আরো উচ্চমানে পৃথিবীর মানচিত্রে বাংলাদেশ একদম জ্বলজ্বল করে জ্বলতে থাকে এই অপথলমোলজিস্টদের জন্য, সেই আশা ব্যক্ত করে আমি ধন্যবাদ জানিয়ে শেষ করছি। ধন্যবাদ।
Thank you so much, madam. Madam, you are an inspiration for us, and only with your guidance we can move forward. So thank you so much. Now we will move on to the president of BSCRS, Professor M. Nozrul Islam. Sir, would you please say a few words and share your screen?
Thank you so much, Majiba. এতক্ষণ ধরে ম্যাডামের বক্তব্য শুনলাম, এক্সেলেন্ট। ম্যাডামের বক্তব্য শুনলে মনে হয় অনেকক্ষণ শুনি, অনেক ভালো লাগে। তো আমি মনে করি বাংলাদেশে শুধু না, এই সাউথ ইস্ট এশিয়ান রিজন, এশিয়া প্যাসিফিক রিজনের লিডার ইজ আওয়ার ম্যাডাম প্রফেসর আভা হোসেন। শি ইজ দ্য ইন্সপিরেশন, শি ইজ অ্যাকচুয়ালি শি ইজ আওয়ার আইডল. Many people say she is idol of many of us. She is our teacher, and definitely we are following her. She is our proud from Bangladesh, not only from Bangladesh, of this Asia Pacific region. And definitely, Madam is going to be president within few months of the Asia Pacific Academy of Ophthalmology. Today, Bangladesh Society of Cataract and Refractive Surgeons are very happy to have you, Madam, as a chief guest. Dear friend, Professor Sharfuddin Ahmed, as Dr. Mahabur Rahman Chaudhary was saying, is also my friend. We are same batch from very early time. We are friends and we are very proud. He is our leader also, leader of the Bangladesh ophthalmologist, all of the ophthalmologists. He is the president of the Ophthalmology Society of Bangladesh. Thank you very much for joining to this inaugural session. I'd like to thank Chairman Scientific Subcommittee, Dr. Mahabur Rahman Chaudhary, to be here in the inaugural session. Our nucleus of the society, Secretary General, Dr. Shaukat Kabir, he is also here. And as Madam was saying, our daughterly colleague, Dr. Mahajibur Rahman Chaudhary, she is also here as moderator. All respected faculties, panelists, speakers, and participants in this virtual annual conference of BSCRS, good afternoon to all of you. As you know that this is the actually 6th conference of Bangladesh Society of Cataract Refractive Surgeons, but first virtual conference. Though it is a virtual meeting, but we try to arrange it as acceptable as possible to our participants, not only from Bangladesh, but also from many other countries. And we believe in the virtual meeting, anyone can join from any part of the world. Only thing, we cannot greet each other physically. We started our journey in this session of 2020 only in January. We had a lot of inspiration. We have a lot of plan to do the whole 2020. But you know, because of the COVID-19 infection, globally, we became in a different world and new normal. So everything is stopped. Only we could do a CME at Bangabandhu Sheikh Mujib Medical University before the COVID lockdown. And after that, definitely we had to stop for some days, some months. Though we started doing webinar, how to do our practice, how to live in the COVID time, along with our members, along with the executive committee members, and also along with the OSB members, with our president, Professor Sharfuddin, and others. And by this time, very unfortunately, we lost our colleague, Dr. Jahangirul Mukut, in June. And again, we are very shocked and stopped everything. We could not think of doing anything. But after some months, we thought Professor Dr. Jahangirul Mukut will feel better if we go on according to his guideline, according to his wish, to the academic activities. So started again to do something. We did webinar with the Indian and West Bengal doctors along with the BSCRS. And last month, in October 3rd, we did the Collaborate. And many of you still remember, it was really a successful program with our friends in West Bengal, ophthalmologists in West Bengal. It was very good one-day program. And you can see that it was also managed by event management. We had beautiful halls, beautiful corridor, beautiful 2 halls of naming Jahangir Alam Mukut and Dr. P.K. Chatterjee Hall. So there are 2 halls in the whole session, the whole day. It was really a successful, lot of education, lot of learning skills. Definitely, we did not have this kind of attendance that we had Collaborate in 2019. But fortunately, we found that many sessions, we find many of your doctors from India, from Bangladesh, and also from other countries, from Singapore, we attended this virtual meeting. And these are some of the memories. This is the life surgery that was done from Dhaka, from Chennai, from I think from Aurobindo Eye Hospital, and many other places. At the same time, in the Zoom, it was telecasted, and we could enjoy the life surgery, probably the first time virtual life surgery in the world. We started it, and today you have seen the life surgery in Bangladesh Eye Hospital, a toric IOL and the multifocal IOL is implanted in the 3D microscope, the RT 800 microscope. So that is also we could telecast it throughout the world today, to this morning. These are some of the memories of the Collaborate, and many people actually, we attended different sessions. Really, we cannot forget beautiful arranged, and that also managed by the MNC, and really we're grateful to them. It was really nice. And this time also the same company were arranging our conference in the BSCRS. Today, it is virtual conference. Definitely, like the Collaborate, we cannot see each other, but definitely we can see the photos, we can see the videos. So that is the thing that we are enjoying. We are learning education and everything in the virtual mode. This time, this is our convention center. It is virtual. But definitely when an attendee and going in the computer screen, you will see like this. So it looks like you are going to a hall. Then you are going to a lobby. Then you are going to a hall inside. And inside the hall, you can see the live presentation. And not only that, we have sponsors stall. If you go to the stall in the exhibition hall and click there, you will find distribution, you will find general, you will find popular, you will find all of the sponsors stall there. You can interact with them. You can see their videos, you can see their products, you can talk to them, you can chat with them. So this is actually virtual, but we have most of the facilities not less than a physical meeting. For this occasion, our website has been very dynamically managed, and you can see the promo video. You can see all the sessions. You can see here all the sessions posters are there. And as Dr. Shaukat Kabir mentioned, we are very fortunate that we are having different category, different societies attending as a partner in the annual conference of BSCRS. We are thankful to the Indian Implant Society, Refractive Society, IIRSI, and also the APSCRS, Asia Pacific Academy of Cataract and Refractive Surgeons, and also FACO mentors for attending and taking partner symposium in our conference. In this moment, I'd like to thank Dr. Ashraf for arranging and bringing them to our society of the IIRC, Dr. Ishtiaq Anwar, who actually the connecting person for the FACO mentors and APSCRS. And definitely on behalf of BSCRS, we want to thank the IIRSI, APSCRS, and FACO mentors to come with us, to have giving their time to contribute their knowledge along with the BSCRS. So this is the session by IRSI, and many very internationally reputed doctors like Michael Sachdev, Amar Agwal, Mohan Rajan, Rohitam Prakash, Dr. Ramamurthy, Priyan Narang, Dr. Sri Ganesh, Chitra Ramamurthy. So many very internationally famous ophthalmologists will talk to this meeting. At the same time, in the APSCRS setting, the Graham Barrett, we are always hearing the Graham Barrett. The Barrett, I will formula, Barrett is the king now in the cataract surgery. He will be in our conference. He will be talking in our conference. Professor Basabada, he has a lot of contribution for Bangladesh, for teaching, for learning the FACO, and he will be here. Dr. Ron, he will be here. So many important internationally reputed doctors, surgeons, they will be talking in our conference today. The FACO mentors, I have attended some of their webinars. It's so beautiful. They do workshop so nicely in the workshop, and they do in such a way that everybody understand their subject. Maybe toric IOL, maybe multifocal IOL, maybe other subject. Very nice. Hopefully, we'll enjoy their session tonight. First of all, on behalf of BSCRS, I'm really thankful and grateful to all the executive members. I'm not mentioning all the names, but all the executive members and advisors in our society, especially Professor Din Mohammad Nurul Haq, Professor Jalal Ahmed, Dr. Mahbub Chaudhary for their advice and blessings all the time. My heartfelt thanks again to BSCRS Scientific Committee Chairman, my friend, Dr. Mahbub Chaudhary. He's always behind us, always making how we can make the scientific sessions beautiful and without any problem, without anything. So always he's working with us. Our Secretary General, as I said, he's the nucleus. He's the right person to go ahead dynamically. He's Dr. Shaukat Kabir. He's always with us, day and night, working with us. Dr. Ishtiaq Anwar is so dynamic surgeon, so dynamic person. And if Ishtiaq is there, we forget that we have to do anything. He can move ahead. He can go ahead. And of course, Dr. Office Secretary, Dr. Ashraful Haq is same. So we are so fortunate that in our society, we have so much efficient colleagues. They can do many things. They can do better than us. And last of all, I like to say a name is special. That is a special thing for our very young colleague, Scientific Secretary, Dr. Mahajibur Rahman Chaudhary. I say it is special because she really has done so efficiently, so devotedly in this conference. She did work very hard, day and night in the last more than a month. So if I have to give any medal, definitely I would give the medal first to her in our society. I must thank the persons behind the whole program. You know that not only the persons in front, many people behind us, they are also helping us to do this conference right way. The technicians, the IT personnel, and many of our staffs at the BEH, Bangladesh Eye Hospital. As our Secretary General, Dr. Shaukat mentioned, our sponsor partners, they are not only the sponsors, they are our partners. They are always with us to promote education, to promote the contribution to our members of the society, to our people of Bangladesh. We are really thankful for extending your hands to our program and make it successful. I believe the meeting will help all ophthalmologists to update their knowledge and skill. Thanks to all participants and honorable chief guest, my teacher. I always say that Abhay Madam is my teacher because this is first thing comes in my mind. So big person, but I am so fortunate. I'm so proud. She's my teacher. So I always say that she's my teacher, our chief guest, and a special guest, Professor Sharfuddin Ahmed, to come to the and giving their very special time. They are so busy, especially Abhay Madam is so busy. She's busy with APAO, busy with SARC, with many things. Still, when you invited her, she said, I will give priority to your conference. So thank you, Madam, once again for having being with us in this conference. So last of all, we are welcoming to this meeting. Thank you, everybody. Good afternoon, and thank you all. Thank you very much.
Thank you so much, sir, for your kind words. And it was only possible because of the guidance of our leader, our Professor Nazrul Islam, Dr. Mahmoud Shaukat Kabir, that we could hold such a conference. And now we are at the end of the inauguration session, but as a physical conference, now it's time for the lunch and prayer break. But there are many exciting sessions waiting for us from 2:15 in the afternoon. And I invite you all for the next sessions. And now we end our inauguration session. Thank you all.
Thank you, madam. Thank you.
Thank you,
Thank you, madam. Thank you, madam.
বন্ধু
Thank you,
নজরুল
sir.
মাহবুব তোমাদেরকে ধন্যবাদ ম্যাডাম তাহলে খোদা হাফেজ শওকত মাহাজিবা খোদা হাফেজ নামাজে যাই হ্যাঁ থ্যাংক ইউ
ভালো থাকো
ম্যাডাম সময় থাকলে সেশনে ঢুকবেন ম্যাডাম
হ্যাঁ নজরুল
দেখি আমি
অবশ্যই
বিকালে ঢুকবো বুঝছো শওকত
হ্যাঁ
দিকে ঢুকবো
এই লিংকে ঢুকে
ভালো এই লিংকেই ঢুকবো ওকে ফাইন থ্যাংক ইউ
IRSI APSCRS ডকুমেন্টর খুব ভালো সেশন হবে আশা করি
অনেক সুন্দর
আমি 5টার থেকে থাকবো ইনশাআল্লাহ
অবশ্যই
ইনশাআল্লাহ স্যার
থ্যাংক ইউ
মাজিবা
থ্যাংক ইউ
শওকত
Thank you, madam. Assalamu alaikum, madam.
Thank you. Thank you.
ভালো থাকো ভালো থাকো
এটা কি এখন লিভ করব নাকি
Okay, we are leaving now. Thank you very much, madam. Thank you.
Thank you.